A very good morning. Welcome you all for this Oral Rheumatology Forum, a complete virtual summit. And this is the second session, completely focused on psoriatic arthritis. And we had a very fantastic case discussions earlier on rheumatoid arthritis. And this session is we completely focus on psoriatic arthritis. And as you know, psoriatic arthritis is not only disease of skin and joints. It has got various systemic complications and 30 to 40% of our patients with psoriatic arthritis are not responders. So with this focus on mind, we have six interesting case discussions by the eminent rheumatologists throughout India. And we also got masterclass sessions from Dr. Atul Diodar, an international lead expert in psoriatic arthritis and spondyloarthritis. And we have Dr. Ramesh Joyce from Bangalore. And we have expert faculty moderators, Dr. Jan Matthew from CMC Vellore, and also Dr. Ganga Ratna Krishna from Mangalore. So with this brief introduction, we'd like to start this summit with a welcome address from Dr. Arvind Chopra sir. And to introduce Dr. Arvind Chopra sir, he is an eminent rheumatologist from India, and he represented Indian rheumatology worldwide, and he has got more than 40 years clinical experience in this field. And he did his undergraduation and post graduation from Armed Forces Medical College, Pune, and he has got many research publications and awards. And he was awarded first IRA Master Award in 2019, and he's the coordinator WHO ILR Popcode Study 2005 till date, and he is the founder and chairman for the Bone and Joint Decade India, and he's also the ambassador for the same worldwide. And he is currently working as a director and clinical chief rheumatologist, Center for Rheumatic Diseases, Pune. With this brief introduction, I would like to invite Dr. Arvind Chopra sir for his welcome address. Over to you, sir.
Thank you, Dr. Damodaran. Good morning to all of you. It's indeed my privilege to welcome you all to this wonderful conference and the second and the last day of the meeting. First of all, I acknowledge with gratitude the wonderful work put in by Ajit Nalavade and his team members. I'm glad that the coronavirus could not stop them from producing such a wonderful webinar-based meeting. So congratulations to all of you, to all the speakers, to all the participants. So friends, let me begin by saying that the precise, I think, prevalence of psoriatic arthritis is not yet known in India. But if I can share you my own experience from the COPCOR studies, which were all India, we had several sites, almost 17 to 18 sites all over India from north, south, east, west, and we gathered a data of more than 1 lakh population. We were surprised that in actual population surveys, we didn't find much of actually psoriatic arthritis. So I believe that you see much more psoriatic arthritis in a hospital setting, tertiary setting, than what you actually see in a community setting. Having said that, we have come a long way since we can see from the literature the earlier descriptions of psoriatic arthritis. But I think it's a seminal paper by Moll and Wright that every rheumatologist must read, which was published in 1973. I remember on my medical college days, I was an MBBS then, second year, I remember that. And later during MD days, this is a great paper. Most of the things that Moll and Wright described are still relevant, except that we've added some risk factors and we have added a little bit more of enthesitis, dactylitis. We've also recognized the role of psoriatic arthritis in premature atherosclerosis and coronary artery disease and some other unique features, but it's a great paper. Now, if you know psoriatic arthritis, then I think you know a large part of rheumatology. One of the most striking features is that psoriatic arthritis is a very heterogeneous disorder. Sometimes the phenotypes really beat us in differential diagnosis. You could be looking at a single joint, you could be looking at a full-blown picture like rheumatoid arthritis, or you could be looking at actual disease, or you could only be looking at dactylitis, or only nail disease, or only enthesitis. However, it's the skin which is at the root of perhaps the entire syndrome, but we still lack good biomarkers to describe some of these very precise subsets which have overlapping phenotype, but they are difficult to disease and they still challenge our therapeutic faculty. Click, please. And Therefore, I think it's important to remember that though we know a lot about the pathophysiology of the skin psoriasis, and we know a fair amount of what happens in psoriatic arthritis, we still have very little data how these two are connected. I think that's very important. And next slide. So, yes, it's true that despite all that we have, I would say, against methotrexate, there's much more for methotrexate. It is a cornerstone of therapy. We must remember that unlike many other autoimmune inflammatory disorders, steroids have a contentious role, and maybe somebody will talk about it. There's been a revolution of therapeutics for psoriatic arthritis in the last 2 decades or so. Most of us have had excellent experience with anti-TNF reagents over the last couple of years, and I think now we're in the era of blocking interleukin 12, 23, interleukin 17 axis. It's important to remember that what all we have today in the armamentarium of psoriasis, the response on the skin is much, much better than the arthritis. I think, in my personal opinion, I think we still don't have very effective long-term treatment for psoriatic arthritis. At least even the clinical drug trials, though they have shown promising results, but I think there's a little bit of a problem. Hopefully, better mechanistic grip on the disease will help us in describing more precise drugs. And I do believe that dactylitis and NSAID still continue the problem, though we've got wonderful drugs. Psoriatic arthritis, we know a lot about the pathophysiology, and there are several biologics. We have some experience with interleukin 17, and maybe somebody will talk about it today. Uh, Treatment of psoriatic arthritis biologics certainly is a challenge to our pronunciation. I think it's a real tongue twisters. There are, to my best of knowledge, at least there are 4 interleukin 17 inhibitors: sequinumab, ixekizumab, bimekizumab, and brodalumab. And there are about four, I think, interleukin 12, 23 inhibitors. Most of them have been in phase 2, some in phase 3. Ustekinumab data is very impressive. You've got guselkumab. Risankizumab is a promising drug in some recent trial, better than ustekinumab, even in skin. And then there's tildrakizumab. You can spend a week trying to remember all these names. So I think with yes, there are newer mechanisms of actions and targets which are still waiting to be explored. Personally, I've been involved with CD6 inhibition. I think some of you were part of a multicentric drug trial in rheumatoid arthritis with itolizumab. We are very impressed, and we in CRD Pune have had a very preliminary experience of treating at least 10 patients with psoriatic arthritis with itolizumab. And whatever I can say, the results are as impressive as what we could see with anti-TNF. Unfortunately, this drug has not been further developed. It's approved for treatment of skin psoriasis. So, friends, I think I can now pass on the baton and wait for further presentations. There are several interesting clinical cases. Clinical cases certainly provide unique flavor to our understanding of the disease. And my friend Atul, who's going to come later in the day, is truly a master and basically a Pune boy. So we all are very fond of him. And I'm sure his heart beats and bats for Pune very often. So thank you very much. It's been great attending, organizing this particular meeting with Ajit, with whatever little we have contributed. Good luck and best wishes to all of you for a wonderful Sunday spending with psoriatic arthritis. Thank you.
Thank you, sir, for your wonderful introductory remarks on and complete overview on psoriatic arthritis. And now we're going into the interesting case discussion part, and we have got three interesting cases on psoriatic arthritis, and the three cases will be discussed in 30 minutes, followed by a discussion, 15 minutes discussion, and for that we have three case presenters. Dr. Hema M, Assistant Professor of Rheumatology, Stanley Medical College, Chennai. And we have got Dr. Manoj Khatri, Consultant Rheumatologist, Medipulse, Jodhpur. And we have got Dr. Abraham Mohan, Consultant Rheumatologist, Caritas Hospital, Kottayam. So with this introduction, I would like to invite our first speaker, Dr. Hema M. Hema, please.
Yeah. Good morning, one and all. I'm Dr. Hema from Stanley Medical College. So I would first thank all the organizers of World Rheumatology Forum, and also my special thanks to Dr. Vinod Ravindran sir for giving me this opportunity. So my case, he's a 35-year-old male. He got admitted in general medical ward in March 2019 with complaints of pedal edema, fatigability, and frothy urine. History of no, there's no history of breathlessness, oliguria, or hematuria. There's no history of fever, sore throat, or abdominal pain associated, but he gave history of joint pain. The patient was taken over by the nephrologist in view of elevated renal parameters and in view of elevated protein creatinine ratio. The renal biopsy was also planned. Since the patient had polyarthritis, I was called in for opinion. And probing his history, he gave history of psoriasis for past 3 years, but he was not on any allopathic medications. He was only on Imani medicines on and off. Next slide, please. So clinical examination revealed his vitals were stable. He had psoriatic patches, both healed and fresh patches, and his he had scalp psoriasis also. His musculoskeletal examination revealed he had a thoracic kyphosis. He had an active knee and ankle arthritis. His Fabers was bilaterally positive, and his Schobers was also positive. He had severe low back pain. He was not able even to stand. So I made a provisional diagnosis of psoriasis with psoriatic arthritis with CKD. Next slide, please. So these were the investigations on the day of admission. His total count was normal. His hemoglobin was low, like it was 6.4, and his platelet was elevated, like 8.6. And he has a very high ESR of 60/138. And his urea is 51, creatinine is 2.5, and his urine albumin was 3+, and urine PCR was 9.93. And his renal Doppler, which revealed no renal artery thrombosis, and his ultrasound KUB revealed a bilateral grade 2 medical renal disease. His peripheral smear showed a microcytic hypochromic anemia. And from my part, I asked for these investigations. His sacroiliac joints MRI showed a bilateral asymmetric sacroiliitis. His HLA-B27 was negative. In view of starting further treatment, I asked for viral markers, HIV, MAN2, and CT chest also, which are all normal. Next slide. So this is a clinical photo of the patient. You can nicely see the healed psoriatic patches actually. And you can also see a thoracic kyphosis, like prominent scapular blade. Next slide. And the renal biopsy came, and there's a report. He had the renal biopsy report revealed suggestive of amyloid. It showed this is a Congo red stain. We showed an apple green bifringence under a polarized microscope, and this is a PS stain which shows a silver negative material, and this is one which shows the amyloid deposition. Next slide. So this is clear. Okay, this is a glomerular cut. We can see the amyloid deposition here, pink amorphous material. This is suggestive amyloid. So I revised my diagnosis. Next slide. So I revised my diagnosis as a case of psoriasis, psoriatic arthritis with renal amyloid. So since I thought like the patient would benefit from a biological therapy rather than the synthetic DMARDs, which I couldn't start in this patient because he had a CKD, I discussed with the nephrologist regarding the pros and cons of starting a biological therapy. Initially, nephrologists were a little reluctant in starting an TNF alpha blockers in him because they were for the fear of infection and so on. So we had a detailed discussion with them, and I planned to start an injection infliximab. So I gave him an infusion of injection infliximab 200 milligram as a regular standard protocol of 0, 2, and 6 weeks, and then I gave him monthly therapy. So the patient received a total dose of 9 doses of injection infliximab, along with I gave him a tablet colchicine also. Till December 2019, he received infliximab, but since the government medical college, there was little difficulty in availability of the drug, so he didn't receive the drug for 2 months. So he presented in February 2020 again. Slide, please. Yeah, with a flare of the disease and worsen renal function. But during the course when he received the drug, his renal functions improved dramatically, and his urine protein and PCR also decreased. So I restarted him on injection infliximab again in February 2020. Next slide, please. So this is a slide showing how his renal functions improved with the infliximab therapy. This is the initial thing. You can see like his ESR is very high, 60 by 138. This is at the end of December, October. You can see how drastically the ESR has come down, and also the urine albumin, which was 3+ at the start of therapy, has dramatically decreased to 1+, and to the surprise, the urine PCR came down dramatically to 1.2 compared to the previous, which was 9.93. So again, this was in February when I restarted the drug. See, at the time of admission, again, his urine protein was 3+, and his urine PCR was 5.89. This is the time which I initiated the drug again. Next slide. So the course of the patient was like the patient didn't come for follow-up after that, like after he received the last dose in February 2020, because of the fear of COVID everywhere. But he presented to my OPD again in June 2020 with severe oral ulcers, and he gave a generalized fatigability. So his basic investigation at that time again revealed an elevated urea, creatinine, OTPT. His ESR and CRP is very high. So I thought of a patient may be having a COVID positivity. I asked him to get admitted, but that time we had a florid COVID cases in our government medical college, so he refused to get admitted. But again, I received the patient in a intubated state to an ICU. He was diagnosed to have COVID positive outside, and he had features of DIC and MODS, but the patient succumbed to illness in spite of the treatment. So why my case is important here is the early onset of amyloid in psoriatic patient whose disease duration is very, very less, like 3 years duration. He had psoriasis, he had psoriatic arthritis, and also renal amyloid. That's why I wanted to focus this patient. But again, I want to focus second point is he had a very good response to the TNF alpha blocker. Even though we don't have a specific drug for treatment of secondary amyloid, treating a primary disease will definitely help in improving the associated status. So here in my case, controlling the psoriatic arthritis and also psoriasis, he had a very good improvement in the renal status also. But unfortunately, he succumbed to COVID. Next slide, please. So this is a slide showing the prevalence of secondary amyloid and rheumatic diseases. This is from Annals of Rheumatic Disease. As you all aware of, like amyloid is commonly associated with rheumatoid arthritis in our illnesses. Like the prevalence is 5 to 20%, whereas in psoriatic arthritis it was around 10%. But again, this is an UK-based studies which showed the prevalence of amyloid in RA is 23 to 51%. Comparatively, in psoriatic arthritis it is only 4%. Next slide, please. So this is from Italy-based study which showed that the peak incidence of amyloid in a psoriasis could be like in the 6th decade, or it will be like around after 10 to 12 years only you have the manifestations of amyloid. It is not so in our case, which he had an early manifestation of amyloid. And the most frequent amyloid manifestations were in the kidneys. Yes, in our case also we had the manifestation in kidneys, and the next will be in the GI tract. And in that study, 29% of patients suffered from pustular psoriasis and 86% had arthropathy also. This is again a study which was published in BMJ, like comparing the prevalence of amyloid in RA and psoriatic arthritis, and also the like in the individual organs. Like you can see again, the prevalence in the kidney is very high, and in amyloid in RA we have high prevalence in lung, whereas we don't have that in psoriasis. Next slide. I think I end up my case here. So this is, again, I would like to state that I presented this case because the early onset of amyloid in psoriasis and psoriatic arthritis and very good response to TNF alpha blockers. I have chosen infliximab because I thought it could be very efficacious in this patient. Thank you so much.
Hello, good morning, everyone. I'm Dr. Manoj here. Next slide, please. I'm presenting a 36-year-old male gentleman's case. He was first psoriatic arthritis patient for me in my private practice, and he was one of the challenging cases that I've seen throughout my career. So he is salesman by occupation, but currently is unemployed because of his illness, because of both psoriasis and arthritis. So he has a history of psoriasis vulgaris for the last 13 years, with a history of arthritis involving small joints of hands and feet, with large joints, with dactylitis, enthesitis, and low back ache for around 4 to 5 years. He has been treated with NSAIDs, steroids, methotrexate, leflunomide, sulfasalazine, and cyclosporine in various combinations earlier. He had never visited a rheumatologist before this. He had visited multiple orthopedicians, physicians, and he had even tried some Ayurvedic and homeopathic treatment, which has not worked well for him. Now, in February 2020, he presented to me for the first time with worsening of joint pain involving small joints of hands, feet, both the knees, ankles, hips, wrists, elbows, shoulders, low back pain, and neck pain. He had pain everywhere. Along with that, he had worsening of skin lesions in terms of spread of skin lesions as well as worsening scaling of the skin lesions. Next slide, please. So on examination, he had chronic plaque psoriasis with around body surface area involvement of 60% with thick scales. He had superadded skin infections on both the legs. Nail involvement was also seen in terms of oil drop sign seen in one nail and onycholysis seen in two nails. Is both the feet were diffusely tender and swollen. Both the ankles and knees were tender and swollen. Both the hips were tender and there was restriction of movement. Right and second and third digit showed dactylitis. First IP and fourth MCP joints were tender and swollen. Next slide, please. Left hand, first, second, and third MCP were tender and swollen, and first IP joint was also tender and swollen. Both the wrists were tender, swollen, and deformed. Both the elbows and shoulders were tender. Whole of the spine and both the SI joints were tender. Amphiceal tenderness was noted at both the ankle insertion, ASIS, iliac rest, and posterior superior iliac spine. Other systemic examination was within normal limit. Next slide, please. So investigation showed the anemia with hemoglobin of 9.3. His count were raised like 18,700, probably secondary to skin infection with which were neutrophil predominant. Platelet count was fine, but his creatinine was raised. It was 1.7. And we had multiple reports of his creatinine which were between 1.6 to 2.2. So there was persistent raised creatinine in this case. AST, ALT, ALP were normal, and total protein albumin both were low, probably because of malnutrition and the illness that he had. ESR and CRP were raised. Viral markers were negative. Urine RM was normal. Chest X-ray was normal. USG KUB was done to look for kidney size, and it was normal. Montu NAV could not be done because of the skin lesions that he had on both the forearms, and IGRA was done, which turned out to be negative. I do not have much of the pictures of the patient, but I have an X-ray which shows grade 4 SI joint changes as well as protrusion acceptably. Here I want to concentrate on one thing is though IGRA was negative, but unluckily I can't actually say that the IGRA was really negative because I have sent 22 to 23 samples from this place of IGRA, and all of them have turned out to be normal and negative. Next slide, please. So I diagnosed the patient with psoriasis vulgaris with 60% body surface area involvement with superadded skin infection, with nail psoriasis, with psoriatic arthritis, with peripheral arthritis, or with tender joint being 40 and swollen joint being 34, with enthesitis, with masses 9, with dactylitis involving two fingers, and then spondyloarthritis, Barsley of 9 by 10. His pain was 90 and he had persistent raised creatinine. Nephrologist has opined that it is probably secondary to NSAID abuse, and he was diagnosed to have NSAID abuse related CKD. Next slide, please. So I started certain antibiotics, gave him tramadol, paracetamol, and clonazepam for 2 to 3 days. Once infection on legs started subsiding, I gave him intra-articular injections in both knees and shoulders, and intralesional injections in dactylitis fingers. Later, he was started on methotrexate and adalimumab. So methotrexate, I had started on 10 milligram per week, and then adalimumab I had given him first dose on 24th of February. After that, in March, patient there was lockdown. He could not take the adalimumab regularly because of his financial condition also. And he came to me on 12th June when I gave him fifth dose of adalimumab. In between, he had taken 4 doses, and actually his hips were bad, and we had planned for THR also. Next slide, please. So on 12th June, when I saw the patient, he had tender joint of 6, swollen joint of 4, pain was 30, there was no dactylitis, masses score was 2, Bast was 4.8, and body surface area enrollment was 30 to 40. So I think the response was quite good, even though he had not taken the doses in so regularly as advisable. So I was in favor of continuing the adalimumab in more regular basis. Next slide, please. So on 25th of July, he had in between that period he had not taken even a single injection because of financial condition. So he had presented to me with fever, decreased appetite, and weight loss for around 1 month. Examination revealed right axillary lymphadenopathy. Um, CCT chest and abdomen was done, which was normal except axillary lymphadenopathy. FNAC was done, which was reactive. We had a strong suspicion of tuberculosis, so biopsy was done. It was suggestive of tuberculosis lymphadenopathy. It was AFB positive, and they were ill-formed granuloma, which I think is consistent with TNF, anti-TNF antibody use. He was started on ATT on 9th August, and following this, I advised him to continue adalimumab and paracetamol, and advised to stop methotrexate and adalimumab. Next slide, please. So on September 12, I had seen the patient again. The body surface area normal was just 30%, which was almost same what I had seen 2 months back. Tender joint count had raised to 12, swollen joint count was 8, pain was 50, Bas was 7.2, there was no dactylitis, and Marshall score was 6. So patient had started worsening now, but still patient was in better condition than what I had seen him in February. So, but there was one more issue here. The patient had started consuming morphine and injection of pentazocine, and he actually demanded the same from me on the prescription. I had asked him to see a psychiatrist, but he refused to see a psychiatrist. Knowing not what to do, now I started on apremilast, thinking that it might work. But after 20 milligram BD dose, he started developing diarrhea. It was restarted once, but because of chronic diarrhea, we had to discontinue apremilast. Next slide, please. So case summary is 36-year-old gentleman with psoriatic arthritis, with deforming arthritis, enthesitis, dactylitis, and spondylitis, with stage 3 CKD, probably secondary to NSAID abuse, who has failed on multiple conventional DMARDs, had partial response to adalimumab, developed TB lymphadenitis on adalimumab, is not tolerating apremilast, and now abusing opioids. So next slide, please. Next slide. So I have two dilemmas here, whether the use of opioids is justifiable. I have personally used opioids earlier in patients of spondyloarthritis, just for a bridge period of 4 to 5 days when the patient can actually get biologicals. So I don't know, because the problem here is opioid abuse is very common in this part of country. So I was not sure whether to continue opioids. Now I think we have more options like tapentadol nasal spray. Probably it is an opioid but has got to less chances of abuse. So that is one option I feel I can give now. And which DMARD to be started next and when? The reason is the patient has active tuberculosis. I searched for literature, but I could not find much of evidence on what to start in a patient who is having active tuberculosis. Thank you. So I have two questions that I've raised. I'll need the expert opinion from the speakers. Thank you.
Good morning, everyone. I'm Dr. Abraham. I'm from Kottayam. I work at Caritas Hospital. I thank the organizers for giving me this opportunity to present this case, and as well as CRD Pune, where I first seen this case. So I'm presenting a 40-year-old male who first presented with skin lesions, which are non-itchy, raised rash, and it is extensive involving the upper limbs, lower limbs, as well as the back since 8 years back, which is followed by incidence onset low back pain, which is in the lumbosacral region, with alternating buttock pain. It is characteristic of inflammatory back pain. The symptoms are slowly progressive, and the course is characterized by partial remission and relapses. Patient also had associated symmetrical polyarthralgias. Subsequently, patient developed diffuse left leg and foot swelling with a non-healing ulcer involving the left lower limb since 3.5 years back. Next slide, please. So there is no significant past history and family history. Patient is a smoker since 20 years and he consumes alcohol 4 to 6 times per week. Treatment history, he was started on hydroxychloroquine and sulfasalazine, which is 8 years back. 2 months he took monitor therapy and thereafter it was unsupervised. He's on homeopathic treatment on regular basis. Next slide, please. On physical examination, patient had bilateral pitting pedal edema, left more than the right, and had extensive non-healing ulcer over the medial aspect of left leg and ankle. And skin, there are extensive psoriatic plaques over the upper limb, lower limb, and back. On joint evaluation, on walking, he was noticed to have limping. Next slide, please. So you can see that here the patient had bilateral shoulder tenderness as well as elbow tenderness, bilateral knee tenderness with crepitus, and bilateral sacroiliac joint tenderness. Next slide, please. On extended cervical spine, he had tenderness over the spinal process involving cervical, thoracic, and lumbar spine, and there was restriction of movements of lumbar spine, which is present in anterior flexion as well as extension. There were no tender points on examination. There were no other extraarticular features on examination. There were no deformities as such. Next slide, please. So as a patient, you can see the patient had a right elbow synovitis. Next slide, please. The right leg patient had some psoriatic plaques which are healing, as well as some pitting pedal edema. Next slide, please. So this patient had a diffuse left leg swelling. We can see that, and there is an extensive ulcer which is there in the medial aspect of the leg, as well as the ankle. Next slide, please. So the patient's modified CRD Pune version hack score is 15 by 24, and on assessment of pain was patient had 6 centimeter on a scale of 10 centimeter, and grip strength was normal in both the hands, and early morning stiffness was present for 3 to 4 hours. Sleep pattern was disturbed, and the patient's assessment of general health was 40 millimeter on a scale of 100 millimeter. Next slide, please. On investigations, patients had a raised ESR, otherwise the hemogram was normal. Patient had a raised CRP. His alkaline phosphatase was raised, otherwise the rest of the LFT, liver function test was normal, renal function test was normal. Immunology workup, rheumatoid factor as well as ANA was negative. On imaging, ultrasonography was done with arterial and venous Doppler. There is no evidence of any ischemia. There is no evidence of any varicose veins or deep vein thrombosis. And the wound swab culture and sensitive was sent, which showed no growth as such. Next slide, please. So we made a diagnosis of psoriatic arthritis with lymphedema and pyoderma gangrenosum. Of course, other differential diagnoses were thought and were excluded. We done an imaging which excluded any secondary lymphostatic edema. We done an ultrasound. There was no evidence of any tumor and no metastasis. There was no Baker cyst rupture. No evidence any deep vein thrombosis, neither varicose veins. Neither there was any evidence of filarial infection as such. DD for the chronic ulcer, first diagnosis of pyoderma gangrenosum. However, ruled out infection with wound swab, culture and sensitivity. And imaging was done to rule out the vascular insufficiency as well as any possibility of malignancy. And ulcer biopsy, there is no evidence of vasculitis as such. Next slide, please. So this patient we had treated actually with disease-modifying anti-rheumatic drugs. We had used methotrexate, leflunomide, as well as steroids were used. Patient's joint symptoms as well as ulcer had subsided, but patient was getting recurrent ulcers as such. Biologics were not used for this patient, but the left leg swelling persisted as such. So coming to the literature, lymphedema is an accumulation of protein-rich interstitial liquid, which is as a result of congenital or acquired disruption of the lymphatic circulation. Diagnosis is clinical, and other supportive imaging which we can use is isotopic lymphoscintigraphy, which is study the lymphatic circulation, as well as MRI, CT, and ultrasound. Indirect and direct lymphography are rarely used. Next slide, please. So the most common site involved is usually the upper extremities, and the onset of edema is unpredictable and is not related to the arthritis duration or severity. The radiological joint damage progression is related to the edema progression. So we can see here two authors, Kele et al. He had studied the etiology of lymphedema in patients with psoriatic arthritis. So he found that inflammatory arthritis does not cause impaired lymphatic flow as such, and lymphedema secondary to psoriatic arthritis is multifactorial. Quarta et al. They studied two possible. They studied two distinct causes of extremity distension, that is MRI and lymphoscintigraphy. They found two mechanisms. One is tenosynovial inflammation as well as lymphatic vessel dysfunction. They found that patients with tenosynovial involvement and without lymphatic changes had a more favorable outcome to treatment. Next slide, please. So there are some possible theories for lymphedema in these patients. So the most Commonly accepted theory is diffusion of inflammatory processes into the lymphatic vessels, which is a possible cause of chronic lymphangitis and edema. Chronic lymphatic vascular damage can induce abnormalities of the lymphatic vessels, which can lead to dilatation, lack of fenestration, or dermal distal blind loops, with progressive and definitive damage and flow obstruction. There are many other theories actually involving venous obstruction, lymphatic obstruction with the fibrin, etc., which I'm not going into because of time constraints. Next slide, please. So the treatment which has been tried is a trial of corticosteroids can be given. If there is no response to steroids, then we can consider physical therapy with mechanical compression. If we find any response to steroids as such, we can use DMARDs or anti-TNF biologics. If the medical and physical therapy fail, then microsurgery, debulking procedures, and autologous lymphocyte injections may be explored. Next slide, please. So these are various authors which have tried various therapies in patients with psoriatic arthritis and limb swelling. So the first author, Selvarani and group, they had two cases, one with tenosynovitis, one with lymphatic dysfunction. So they tried steroids in this patient. There was successful resolution of edema secondary to tenosynovitis. There is no effect on treating primarily lymphedema. In the next group, Cantinian group, they also used steroids, and they found that this had a positive result in treating swelling secondary to psoriatic arthritis in patients with predominantly tenosynovial involvement. But in patients with lymphatic dysfunction, it is not effective. Next group, Cortain group, um, they had used biologics actually. So they had two patients with MRI and lymphoscintigraphy confirmed tenosynovitis or lymphedema. So both patients' arthritis symptoms are resolved, but there is no improvement in lymphedema. And in the last group, Lepka and group, the patient has psoriatic arthritis, had a left upper arm swelling, which was successfully treated with etanercept therapy. So generally, patients who had predominantly tenosynovial involvement had a response, but DMARDs and biologics didn't show much response in patients with predominant lymphatic dysfunction. Next slide, please. So going through the literature, the most effective therapy which has been for lymphedema has been complex deconstitutive therapy. And this involves skin care. Skin care involves moisturizing skin, protection from infection and trauma, manual lymphatic lymph drainage, which is a sensitive massaging technique, which should be done by a trained person, and then compression using a short stretch bandage technique. So this should be continued till the arm swelling reduces, and then patient should be followed up with a maintenance compression garment, which is specifically made for these patients with the lymphedema. And then patient, the last component involved is exercise actually. So otherwise, the treatment with disease-modifying anti-rheumatic drugs has been inconsistent in lymphedema generally. It has been shown to be more effective in other causes, lymphedema due to other causes such as rheumatoid arthritis as well as angst. Next slide, please. So concluding, psoriatic arthritis with limb swelling due to lymphatic dysfunction is a difficult to treat condition. Coexistent pyoderma gangrenosum further complicated the management of this case. So limb swelling due to tenosynovitis may respond to steroids or disease-modifying anti-rheumatic drugs or anti-TNF therapy. Not gone much into details of pyoderma gangrenosum literature because of the time constraints. Thank you.
Thank you all presenters for your wonderful case discussion on difficult to treat psoriatic arthritis cases. And the case 1 and case 3 clearly implicates the use of alternative medicines which act as potential impingement to the actual treatment in these patients, so that we are seeing a garden variety of manifestations. Usually we don't see amyloidosis in psoriatic arthritis, but the patient was on unanimous medicine, so which the disease got left untreated and leading to amyloidosis. And similarly, case 3, this patient is also on alternative medicines, homeopathy medicines, and the disease was left untreated and leading to the garden variety of manifestations where we don't see commonly these atypical presentations like chronic lymphangitis and the onset of pyoderma gangrenosum on the top of this lymphangitis. And the case 2 is very interesting, and that scores the importance of the pitfalls of quantiferon TB testing in screening for latent tuberculosis in those patients who are going to start biologic agents, and the lack of response to the adalimumab in the case 2 is probably because of the active TB infection, which might have missed by the latent TB screening. Because in India, like we send the samples to the outside, and we don't know because in quantiferon TB gold testing, like we need to isolate the lymphocytes immediately, and we need to incubate at 37 degrees centigrade. So when you're transporting the blood sample, I don't know how strictly we're maintaining. So that's one important question. And definitely in the case 2, we can give secukinumab, like in a meta-analysis of more than 2,000 patients. Among the 2,000, more than 2,000 patients, among them 132 patients who has got tuberculosis, all these patients are safely treated with secukinumab. I think in the second case, secukinumab should be the ideal option. So with this brief introduction, like I want to go to the audience question. This is for pyoderma gangrenosum. Dr. Abraham,
Yes, sir.
have you done colonoscopy in these patients to rule out IBD-related pyoderma gangrenosum?
No, colonoscopy was not done for this patient. Patient had an obvious etiology in the form of psoriatic arthritis, and there's no symptom suggestive of inflammatory bowel disease as such. Anyway, screening colonoscopy was not done because we had an already established diagnosis as such.
Yes, Dr. Rajeshwar madam suggested that we can do a fecal calprotectin level estimation to go to a systematic activity. And Dr. Rajeshwar madam again asked me, can you try etanercept or tofacitinib in the second case? But definitely because this patient has got active tuberculosis, so both tofacitinib and etanercept may not be the good option. Secukinumab may be the ideal option. And Dr. Vikas Sharma asked one question: did you rule out Burgess disease in case 3? Dr. Abraham?
Pardon, sir?
Did you rule out Burgess disease because this patient is a smoker?
Yeah, Burgess disease was ruled out. We had done an arterial Doppler as well as venous Doppler, and there was no evidence of Burgess disease as such.
Yeah. So there's another question: can we use from Dr. Vijay Prasanna? Can we use apremilast along with the TNF inhibitors or interleukin 17 inhibitors? Yes, there may be a rationale to use, but the most common combination we use is methotrexate along with these anti-TNF or that is to prevent the development of anti-chimeric autoantibodies. And then there is another question from Dr. Vikas Sharma: did you rule out heavy metal poisoning in case 3?
Heavy metal poisoning.
Yes.
Uh,
I think this may not be relevant in this case. And there is another question for case 3, Dr. Abraham. Is the lymphedema in psoriatic arthritis related to disease activity?
Lymphedema, it not necessarily always related to disease activity, because once the damage is set and the lymphatic vessel damage is set, it can turn into a chronic lymphedema. So not necessarily, of course, patients who have more disease activity and have a chronic disease are more likely to develop these complications who have uncontrolled disease.
Yes, there's another question from Dr. Rajkiran. Is lymphatic dysfunction commonly bilateral or can be unilateral?
It is commonly unilateral. Most of the cases, what they've seen in the literature, it involves the upper limb, and mostly it is unilateral in these cases, as far as I've gone through literature.
And Dr. Ankul Dalal is asking to case 1, if the patient presented you first time in the COVID-19 pandemic, what is your approach to your patient?
Sir? Question, sir?
If the patient presented to you during the COVID pandemic, so how do you approach the patient?
which means like first time a case of psoriasis, psoriatic arthritis, renal amyloid. So in that COVID scenario, definitely I will not put on biological therapy, first point. Second thing, regarding the renal status, probably I may just stop the tablet colchicine because other drugs cannot be given. And I couldn't consider methotrexate or leflunomide in this patient if he is found to be COVID positive. If he is not COVID positive, then we can put him on probably leflunomide may be my first choice because methotrexate stands second in the presence of renal dysfunction. So in the COVID status, definitely no biological therapy. If at all I need to consider biological therapy, probably I would have considered etanercept rather than infliximab. And second, synthetic DMARDs I would not have considered in this patient because his disease activity was very, very high, and we don't know like how long will the COVID go on. So I cannot keep the patient disease activity active. So I would have considered biological therapy. Yes, if so, probably etanercept. Second choice could also be an secukinumab, but yes, like you can consider either etanercept or secukinumab safely, but with the patient concern and explaining to the patient about the COVID situation and the risk of infection.
And actually, in the case one, the source of the serum amyloid associate is not only from the liver, but it can also from the adipocytes and also from the skin. Also, the skin is also an active source for SSA. And is there any studies of the role of secukinumab in amyloid associated amyloidosis in psoriatic arthritis?
Sir, I have gone through a literature where it was found that IL-17 per se is involved in the pathogenesis of amyloid, serum amyloid proteins and amyloid fibrils. But I couldn't find any study which has used secukinumab in the presence of amyloidosis. So I'm not sure of it, sir. But there is one literature showed that Th17 and IL-17 is definitely a source of production of serum amyloid protein peptides.
Yeah, actually, this patient actually responded very well to the anti-TNF therapy, but unfortunately, this patient died due to COVID. With this, we need to. I would like to invite Dr. Atul Devgar for his expert comments on all these three case presentations. Go to Atul.
Yeah, thank you very much, and I want to thank Dr. Nalaude and Dr. Ravindran to invite me to speak here. And as Arvind said, I am born and brought up in Pune. I went to BJ Medical College in Pune and did my MD medicine, and then I went to England. Even though actually I'm here as an expert, these are unbelievable cases. I haven't seen anything like this in the US. When I left India, of course, that was many decades ago, I used to see these type of patients, and I've seen only 2 cases of amyloid. This is now, I actually taken some notes here. Dr. Hema's case was unbelievable. I've seen, when I was in medical school in Pune, in BJ Medical College, my close friend, his father was a radiologist, and he died of amyloid. He had rheumatoid arthritis, but he had long-term rheumatoid arthritis, very severely deformed hands, etc. That was the first case I saw when I was in medical school related to rheumatic disease. After that, I have not seen any case till I came to US. And I have one lady who has got ankylosing spondylitis. She's from India, and she declined to take, she has got AS, declined to take biologics for the fear of side effects, and she developed amyloidosis. I've never seen a case of amyloid so early, and I agree with Dr. Hema that this is very unusual to have amyloid so early. The literature that you quoted about, there was one slide in your presentation about 10% and 15% and 20%. That is unbelievable to me because as far as, I don't know, I've seen thousands of cases, and I don't know where that literature comes from. Unless it is completely untreated inflammatory burden, people should not be developing such severe amyloid of the kidney. So 10%, 15, this is case reports. I don't really see that at all. So that's just a comment. And so this is a very, very unusual case that you have. There was something about that COVID that I just wanted to, there may be some slight differences. So the American College of Rheumatology came out with the treatment guidelines because we were flooded I mean, as you know, US is way worse than India when it comes to COVID infections and the death rate and all these kind of problems we have. This evening, I was looking at, we have got 3.15 lakh people who have died in the US with COVID. American College of Rheumatology came up with the treatment guidelines of how to deal with COVID infections and patients with rheumatic diseases. So they said that, in fact, what the studies have shown from New York, where we have got friends who admitted patients with COVID infection on biologics, strangely, their outcome was not worse than people who were not on biologic. That's point number one. Point number two, people who were on biologics, at least in the US, for rheumatic diseases, the admission rate into the hospital was not increased, and in fact it was reduced. So TNF, so this is the COVID registry. There is a international COVID registry. People from all over the world have put in their patients into the COVID registry. They found that patients who were on TNF inhibitors had less likelihood of getting admitted to the hospital. Now, this could be ascertainment bias. Ascertainment bias is that these people were more cautious. They were washing their hands. They did not get out of the house. They were very, very cautious, and that's why they had less likelihood of getting admitted. But the December issue of Arthritis and Rheumatology Journal, there is an editorial by a French doctor, and he says that there may be a possibility that, of course, as you know, cytokine storm is a major reason why people die. And if people are already on TNF inhibitor, that might be in fact protective, which I think is a little bit far-fetched. But who knows? I mean, we several things we don't know. So the American College of Rheumatology treatment guidelines say that if you see a patient with active psoriatic arthritis, active rheumatoid arthritis during the epidemic, during the pandemic, please treat him as if there is no COVID. The patient needs to take all the precautions, but you need to treat the patient exactly the way you would treat otherwise. If the patient calls you and says that now actually I have got COVID, then yes, you tell the patient to stop taking the biologic. But if they don't have if they don't have COVID infection, then they should be treated just the way they should be otherwise. And yes, there is one, way back I was looking at this literature. I haven't seen the literature about TNF inhibitors reversing amyloidosis. There is at least one study, and I have got some slides somewhere in my presentations which showed that um, uh, this is actually ankylosing spondylitis, but treatment with infliximab reversed amyloidosis in patients with ankylosing spondylitis. So your experience is true that adalimumab reversed it. But great case. And same thing with Dr. Manoj Kumar's case. And that was that protrusio acetabuli that is unbelievable. I mean, yes, that person definitely requires hip replacement. And I agree with Dr. Damodaran that secukinumab would be the best drug here. Secukinumab should not really have any risk as far as tuberculosis is concerned. Guselkumab, we are, at least in the studies, looks unbelievably safe. Same as ustekinumab. So IL-12/23 inhibitor and IL-23 inhibitor. In the guselkumab, two large studies, of course, clinical trials, you have to take it with a big pinch of salt when it comes to infection risk, because there are less number of patients followed for a short period of time. But in the guselkumab trial, the infection risk in the guselkumab was as bad as placebo, no difference whatsoever. Ustekinumab has a very large data set, which is IL-12/23, as you know, inhibitor. And there again, the infection risk is less. IL-17 inhibition risk for tuberculosis is also less, much lower than a TNF inhibitor. So I would agree with Dr. Damodaran that secukinumab would be a good drug, and guselkumab I wrote down would be another good drug. And I didn't see that Dr. Manoj Kumar's case was, so sulfasalazine and leflunomide was also tried or was not tried. I don't know whether you tried that. You're muted.
Uh,
Yeah.
they had been tried earlier before the patient presented to me. He had been on
I see.
medications last 10 years and had tried cyclosporin, leflunomide,
Yeah.
sulfasalazine, Polytrex, and then along with that, he had even tried Ayurvedic and homeopathic medications.
Yeah, cyclosporin would be a problem with, and methotrexate would be a problem with somebody with renal function
Renal function.
abnormality. And I don't know whether you ever do combination therapy or not, and that's not really been tried. And in my talk, I'm going to talk a little bit about that, that there is a lack of information about combination therapy of conventional synthetic DMARDs in psoriatic arthritis, and probably the data should come from India. Um, but great case. I mean, we still see tuberculosis in the US. We always do the IGRA. We do the quantiferon gold test here, and it's pretty sensitive and specific for us. And we rarely see. Generally, tuberculosis in the US is limited to people with HIV or people who are homeless or who are in jail or prison or that kind of thing. It's not common, obviously, as it's in India. But again, amazing case. And you had two questions. And so your first question was, should we be using
Okay.
um, opioids? And I agree with you. I mean, I worry about using opioids. uh, in India, it is very difficult. In the US, the way we use opioids is not really possible the way you would be using, because we actually get the patient to sign a document which says that I will only take opioids from Dr. Manoj Kumar, and I will not take it from anybody else. And then only you will be able to, and the pharmacies, their electronic system, they will not give the patient opioids unless it comes from Dr. Manoj Kumar alone, not from anybody else. And that obviously is not possible in India. And of course, then the patient goes to somebody else, and then we can tell the patient, no, you're not going to get opioids. I think your second question was, I forget what your second question was. Oh,
What
which biologic,
should
right?
I start now and when?
I would, so once you start them on anti-tuberculosis treatment, then I would start them again on secukinumab, which would be a great drug to start immediately. There is very limited risk, even for anti-TNF drugs. Well, this person actually has anti-TNF, so this is not um, uh, like somebody with just positive test but no obvious evidence. So for anti-TNF, you have to wait for the entire treatment, anti-tubercular treatment is completed. For secukinumab, I would have started him along with anti-TB treatment because the risk is very, very minimal in my mind. Dr. Abram's case was also amazing. I got one lady I remember in my practice currently. She's 90 years old. She has got bilateral leg lymphedema and she's got psoriatic arthritis. And in her case, I got no idea why she has lymphedema. Part of that also, she has got some little bit of congestive heart failure. So it's not just lymphedema, it is regular edema because of her congestive heart failure, but most of it is lymphedema, and we are treating her only with compression stockings and manual lymphatic drainage and etc., etc. Interestingly, the place where I work at OHSU, the wound care people are next door, and wound care and rheumatology, for some reason, we are next to each other, and I can go and get somebody and show them the pyoderma gangrenosum. So was that pyoderma shown on the histology? And so you did do a skin biopsy, and that
Yes,
showed pyoderma gangrenosum and didn't show vasculitis, right?
it didn't show vasculitis. There were no pathognomic findings of pyoderma gangrenosum.
Pyoderma. I
There were
see.
some non-specific findings, but we concluded as pyoderma gangrenosum based on exclusion because all other
So,
possible causes were ruled out.
right. TNF inhibitors. So we have treated pyoderma successfully with infliximab. And in fact, IL-17 inhibitors they were trying for pyoderma gangrenosum. I haven't looked into that, but IL-17 inhibitors might also work for pyoderma gangrenosum. So both TNF inhibitor and IL-17 inhibitors would work. But I have never, apart from that elderly lady who's 90 years old, I haven't seen this kind of significant amount of lymphedema. And it's fascinating, all those pathophysiological mechanisms that you show there. So great cases, amazing. I mean, I admire the kind of patients you see and you deal with. So thank you for presentation, and I learned a lot myself.
Thank you all presenters for your wonderful cases. Now we'll move on to next session, masterclass session. I will hand over the further proceedings to Dr. John Nath.
It's my good morning, everybody. It's my honor to introduce Professor Atul Diodar. After his MD, he's a member of the Royal College of Physicians and a fellow of American College of Rheumatology. And currently is the director of Division of Arthritis and Rheumatic Diseases at Oregon Health Science University of Portland, Oregon, US. He has authored 3 books and several book chapters. He has edited special issues for journals, editorials, and has more than 150 peer-reviewed articles. And I know many of us would debate and discuss his articles during our Journal Club sessions, and we are proud to have him here. He is a principal or co-investigator in more than 100 clinical trials. And his interesting research areas are novel therapies as well as epidemiology and patient outcomes in angst-bound, psoriatic arthritis, and rheumatoid arthritis. Over to you, Dr. Diodar.
Thank you very much, Dr. Matthew. I'm going to share my screen and let's see. Are you able to see my screen?
Yes, Dr. Diodar.
Yeah, thank you. So thank you very much. And I'm delighted to be here again. I was hoping that I would come and visit you in Pune because my mother is 93 years old and she lives in Pune. And when Dr. Nalaude and Dr. Ravindran asked me, they actually invited me last December, or actually last November. So November of 2019, Dr. Nalaude came to me at the ACR annual meeting in Atlanta and said, will you come to Pune and give a lecture? And I said, of course I'll come to Pune. I come to Pune anyway, twice a year to see my mother. And so I'll be delighted to come and give a lecture. But then unfortunately, with everything got canceled. So I'm giving you a lecture from here. So this is a picture of, this is from my university. What the mountain you're seeing is Mount Hood. HOOD. This is 13,000 feet, so what, 3,500 meters tall mountain east of Portland, about 60 miles east. And this is a picture taken from my university. And this is how it looks now. We had a lot of snowfall recently. I'm going to speak on difficult to treat psoriatic arthritis, but then after listening to Dr. Hema and Dr. Manoj Kumar and Dr. Abraham, I'm quite humbled. And your cases of psoriatic arthritis are way more difficult than what I'm going to talk about. In any case, I will give you some of the glimpses of what kind of difficult patients that I see. I mean, your cases had all kinds of difficult other things like amyloidosis and pedal edema and lymphedema and tuberculosis and etc. These are my disclosures. And here is a case. This is the type of difficult case that we would see in the US. So a former fellow of mine, she's in private practice in Central Oregon. She called me and said that she has a 66-year-old male with psoriatic arthritis since 2009. A reliable, upstanding man is what he called him. He has history of peptic ulcer bleed, coronary stents on clopidogrel, and he's on leflunomide, sulfasalazine, and apremilast. And he has right-sided second and third MCP tenderness synovitis confirmed by ultrasound, bilateral MTP tenderness on squeeze, and but the skin was under very good control. So not many tender joints, but a couple of joints which were swollen and tender. But these were causing him a lot of trouble. Only these 2 or 3 swollen tender joints was causing him difficulty in opening jars and doing his day-to-day activities. His CRP was 8.4 and ESR was 5, which I was struck by the amount, these ESR of 100 and 110 in the 3 cases presented to me. We rarely ever see that type of ESR responses here. And this guy had tried 11 biologics and failed. So in the US, biologics are very easily available, as you know. The irregular use that you have, that should be published, and how you manage your cases, because really the world needs to understand how you can use these biologics off and on and still get a good control. We of course use them regularly, and these are the different biologics he had tried and failed. And I'll come to this case again. So this is a situation that I see where patients are sent to me saying that he has failed everything. Now you tell me what to do. He still has got not as many swollen joints or tender joints that you guys see in your patients, but these are joints in his hands that he has difficulty in doing day-to-day control. So just over quickly, this is just one introductory slide I have about psoriatic disease. And this just shows, this is Oliver Fitzgerald, who's in Ireland. He put up this slide of all the present, and you probably have seen this slide many times in other people speaking, but starting from the top left, there is this enthesitis and enthesiophyte in the at the junction of Achilles tendon insertion as well as plantar fascia. This is uveitis, and this is synovitis, and this is acroiliitis, and of course significant arthritis, plaque psoriasis, and then dactylitis, nail pitting, pencil and cup deformity, and involvement of the spine. And so psoriatic disease is a multi sort of different domains are involved, and one has to take into account which domain we are going to use. The treatment of psoriatic arthritis has evolved, and you all know about this. And Arvind said at the start how psoriatic arthritis was recognized for the first time by Mole and Wright. And then till then, of course, it was thought to be just rheumatoid arthritis with skin psoriasis. So non-steroidal methotrexate, leflunomide, and then etanercept was the first drug, and then 4 other biologics, anti-TNF monoclonal antibodies came, and then ustekinumab, apremilast came at the same time. And these 2 drugs, brodalumab is available, but is available only for skin psoriasis, not available for psoriatic arthritis, and bimekizumab is yet to arrive. And so these are the ones that we currently have. Tildrakizumab, risankizumab, and guselkumab are the pure IL-23 P19 inhibitors. Abatacept is not a very good drug for psoriatic arthritis. It is approved though, and tofacitinib is approved, and upadacitinib, this recent ACR meeting this year had 2 phase 3 studies of upadacitinib. This slide shows all the phase 3 studies and drugs which are available for us in the US to treat psoriatic arthritis. So there are 5 anti-TNF, there are 2 IL-17, so that's 7. There is 1 ustekinumab, 8, 1 apremilast, 9, 10, and 11 drugs which are currently available, tofacitinib. And the orange bars are the placebo, and the blue bars are the active treatment, and these are phase 3 trials. As you can see, the anti-TNF are more or less similar, and I agree that the original comments by Dr. Chopra that the newer and newer drugs have become better and better on the skin. However, on the joints, we actually hit a ceiling with the TNF inhibitors, and we haven't been able to break that ceiling. We are still stuck at where we were. About 60% patients get ACR20 responses. So there are all kinds of treatment guidelines. The ACR NPF treatment guidelines, I was part of that. Just Singh Sardar, he's he was the first author on that, and he is also the first author of the RA treatment guidelines. He is in Alabama. NPF is National Psoriasis Foundation. And then there are the EULAR guidelines, and then there are the GRAPPA guidelines. I'm not going to show you any of these because none of these really do justice to what is happening in India, because these guidelines are made for countries like United States and Western Europe, etc. These guidelines, some of you might have seen, these got published just earlier this year. This is International League of Associations, ILAR recommendations for management of psoriatic arthritis in resource poor settings. This is specifically, so, and Vinod Chandran, that almost all of you would know, is one of the authors here, and he was one of the main authors, all these first 5 people. This Ajesh Maharaj, you also might know, he is an Indian gentleman, a rheumatologist in South Africa. These treatment guidelines were written specifically for South America and Africa. They were not written for India because if you read this, they say that APLAR is developing guidelines, and I couldn't find APLAR guidelines, and I could find APLAR RA guidelines, and I could find APLAR guidelines for axial SPA, but not for psoriatic arthritis. And if you guys have it, then I'm sorry, I couldn't find it. You can send it to me. But these are the treatment guidelines for resource poor setting, and I thought these should be really fitting for Indian circumstance. So What they did was they did something called adapt collaboration. So this is a 2009 adopt collaboration process. This has been published as to how to adopt guidelines published by others, and you adopt it for your own country. So classification criteria are uniform throughout the world, because psoriatic arthritis doesn't differ in India as compared to US. The same disease, the same the classification. Treatment guidelines differ, and they differ mainly because of what is available, what is not available. There is tuberculosis there, there's less tuberculosis in the US, etc., etc. So to adopt other guidelines, there is this adopt collaboration process, and there are three phases. One is a setup phase, adaptation phase, and finalization phase. In adaptation phase, there is defining, you define the health question. What is the question for your specific country and your specific area, assessing the source recommendation, drafting a report, and finalization. And unfortunately, what they found, there was such a severe paucity of data that they just could not really form very good guidelines. So there were 6 guidelines. So these are the guidelines. Number one is the goals of therapy. And so they say that remission and low disease activity should be the goal, which all of us would agree with. But they said, beware, all symptoms may not be resolved. So just because you say remission and low disease activity, people may continue to have some pain, and that is because of damage. And I'll come to this point later in my talk. Screening and management. So number 2, 3, 4, 5, 6, they said there is no evidence found to make recommendations. And they specifically looked at recommendations for screening and management of comorbidities like tuberculosis, as we were talking about, what to do, what drug to use. And we said secukinumab, but I mean, this has to be really, these types of things have to come out of places like India or South America or etc. to show to the world that this is how it is, it needs to be managed. HIV, hepatitis B, C, leprosy, how frequently we should be monitoring and what we should be monitoring. Safety and efficacy of pharmacotherapy in, if the way you are using the drugs, because patients cannot afford it, you give it at an irregular basis, but what is the safety and what is the efficacy? It's a very interesting question, and we don't really have good data. Safety and efficacy of combination, as I was saying earlier, combination of the conventional synthetic DMARDs or biologic DMARDs with them. Safety and efficacy of biosimilars. So these ILA recommendations finally said there is no evidence found, and they came up with a research agenda. It is worth reading because this type of research, they said, needs to happen in resource poor countries to show how these diseases can be managed with the limited resources that you have. I will not go into the details, for I don't have too much time, but this is an article which got published earlier this year in Clinical Rheumatology, worth looking at. All right, 10 reasons for the difficult psoriatic arthritis patient, the way we look at it. And of course, this is, I have changed it for Indian circumstance. So poor health care access and inability to afford biologic, that obviously is going to make your life very difficult to treat your patient. Poor health literacy, follow-up is difficult, non-adherence to treatment, allopathy mistrust, and these people have side effects to everything. This is the nocebo effect, which is opposite of placebo. Placebo, as you know, in Latin means I will please. Nocebo in Latin means I will harm. And nocebo effect is that, oh, allopathy is bad, and I will take homeopathy, and I'll take naturopathy, and I'll take Unani medicine. Late entry to rheumatology care, and now from 6 onwards is the problem that we face: failure to differentiate inflammation and damage, enthesitis or enthesalgia. People keep on complaining of pain, and you think it is enthesitis. Wrong diagnosis, and I'll come to some of these explanations about that. Unrealistic expectation from the patient and from the doctor. And then there are these social media patients. I've done my research on WhatsApp. I changed it. Actually, patients come and say, doctor, I know everything. I've done my own research on Google and internet, and I want this drug. I want etanercept, and that's the drug I want. And I know everything. I mean, just prescribe that to me. And so these are kind of difficulties. And first 5 of them, and actually I should put these up. These are, I don't know that we are going to discuss them in today's talk, because there is very little that I can offer, though I got some suggestions in this one. We are mostly going to discuss these last 6 to 10 So I'm sorry about this. I should have looked at this, how this comes up. Um, but look at the first five. The first five: poor healthcare access and inability to afford biologics. I mean, I don't know how easy it is to get biosimilars in India and whether they're really cheap or not. In Britain, infliximab is 85% cheaper if it is biosimilar. So 15% price. And in same thing in Norway, and I got no idea how easy or difficult it is to get in India and how expensive that is. The next three: poor health literacy, non-adherence, and allopathy mistrust. We have to really do patient education, because without that, tackling this issue is going to be very, very difficult as far as I'm concerned. Late entry to rheumatology care. Um, American College of Rheumatology has done a great job in educating other professionals what is rheumatology. I mean, even in the US, people don't understand what is rheumatology and what rheumatologists do. This is something that IRA should do, Indian Rheumatology Association. This is professional outreach, reaching your other colleagues to tell them what is rheumatology and how we can bring in what we bring into the table. So beyond that, I'm going to discuss mostly 6 to 10 in my talk. So number one is failure to differentiate between activity and damage. When we say that my patient is not responding, are we differentiating between active inflammation and chronic damage? Am I treating chronic damage by changing the biologics? This is what happens in the US. And sometimes what is bothering the patient isn't fixable. They have social, economic, psychological issues. They may have central sensitization. And so what we are thinking they have enthesitis is really enthesalgia. I mean, there is no such word as enthesalgia. We created this word, but you understand this. This is the enthesitis and enthesalgia. They have got fibromyalgia, tender points, they have got tenderness. But how much of that is because of central sensitization? And by changing biologics, are we really going to fix that? Central sensitization is pretty common in rheumatic diseases. And I have shown here at the very bottom is psoriatic arthritis is about 18% of patients would have, and these are the authors and these are the papers, would have definitive central sensitization. Here is an interesting study which looked at the effect of the presence of fibromyalgia on the common clinical disease activity indices in patients with psoriatic disease. So this is a cross-sectional study. And what they found out was that the CPDI, DAPSA, DAS28, MDA, these have significant amount of patient-reported outcomes, and they were definitely different. They were worse in patients with psoriatic arthritis and fibromyalgia compared to those who only had psoriatic arthritis. But then look at the next three: CRP, PASI, and swollen joint count. These are objective methods, objective outcomes, and they are not different. The p-values are not significantly different. So patient reported outcomes are definitely different in patients if they have got fibromyalgia along with their psoriatic arthritis. Depression, there is also a high prevalence. And so there is an increased risk of depression and suicidality in several of these cases. So damage versus active inflammation is a very important thing that as rheumatologists we need to look at. And if you are going to treat damage with changing biologics, the patient will never really get better. There are psychosocial issues, there is central sensitization, and then there is this anxiety and more pain and hopelessness and insomnia, and the chronic pain keeps on worsening. And they keep on coming to you asking for narcotics, as we saw in the first case. And if somebody already has got pretty destroyed joints, then any amount of drugs is not really going to help. So managing expectation is extraordinarily important. Could it be that we have got wrong diagnosis? These are some of the misdiagnoses that we see: inflammatory osteoarthritis, overuse, CPPD, and I'll show you a case of my own: gout. I have been fooled in the past. SAPHO, fibromyalgia, seronegative rheumatoid arthritis usually is the other way around. Patient has, people call them seronegative rheumatoid arthritis when they really have psoriatic arthritis, but sometimes it's the other way around also. Early phase of connective tissue disease, infectious arthritis, Whipple's disease, neoplasia, RS3PE, etc. The pseudo psoriatic arthritis or CPPD, I had a lady that she had psoriasis and she had puffy hands and she had classic synovitis of her MCP, bilaterally symmetrical. She was elderly, she had MCP subluxation. The X-ray kept on showing non-erosive arthropathy and they showed chondrocalcinosis, but I was convinced this is psoriatic arthritis. I tried all kinds of drugs on her. She did not respond to any biologic whatsoever. And after I gave up and I said, this really is CPPD arthritis. CPPD, we know, can cause pseudo gout, but CPPD arthritis can cause pseudo RA and can cause also pseudo PSA. Especially in elderly people, it can look bilaterally symmetrical, swollen joints, MCP, PIP distribution, even subluxation. And that is not really psoriatic arthritis, that is CPPD arthritis in the elderly. Inflammatory osteoarthritis, as you know, they have got their elderly, their DIP joints are puffy and swollen. And we, of course, differentiate because they have got knobbly, sort of bony things, and x-rays look very different. Nails are spared. Is it SAPHO? And why is SAPHO important? And that is basically because these people could be treated with IV pamidronate. And 4 cycles, this is not a treatment for psoriatic arthritis, but SAPHO can be treated with pamidronate and their arthritis can get dramatically better. Psoriatic arthritis is commonly mistaken as seronegative RA, but the reverse is also true. And that is important because IL-6 inhibitor, and there is something that, and I'd heard this before also, itolizumab, that was mentioned by Arvind, and I never used itolizumab and anti-CD6. I need to do some research on that. But this is IL-6 I'm talking about. IL-6 inhibitor, rituximab, etc. We will never use um, in in patients with psoriatic arthritis, but the patient may actually have seronegative RA. Gout in psoriatic arthritis. Now, I've had patients who definitely have psoriatic arthritis, and they came with one swollen joint, and I tapped their joint and injected it with corticosteroids. And to my surprise, we found that there was uric acid. And as you know, there is rapid cell turnover. It's a risk factor for incident gout. And the age and multivariate adjusted hazards ratio in this particular study by Joe Marola from New York for gout was 1.71 for psoriasis and 4.95 for psoriatic arthritis. Huge increase in the hazard ratio for gout in patient with psoriatic arthritis because of the rapid cell turnover. So we have to keep that in mind also. And then lastly, of course, we have to think outside the box. And then could it be something else? Now, this is unlikely to happen in India, knowing that the kind of obesity that we see in the US, in India, that kind of obesity is not seen. But obesity is very common in the United States and very common in psoriatic arthritis. And obese patients do not really respond well to the treatment. And just drop in their weight can improve their functionality and their response to TNF treatment. So weight loss, 138 obese psoriatic arthritis patients starting TNF inhibitor, randomized to hypocaloric diet versus self-managed diet. At the end of 6 months, more than 10% weight loss was associated with likelihood of achieving minimal disease activity. So weight loss improves that. And then methotrexate, the SEAM trial, the MIPA trial that you know about methotrexate in psoriatic arthritis showed that methotrexate really doesn't work. So in the West, in the US, people were suspicious methotrexate may not work. But the SEAM trial, which was a trial between methotrexate versus etanercept versus combination, showed that methotrexate is a pretty good drug. Now, this trial can be criticized because there is no placebo. So we don't know how much of this placebo response, but methotrexate works. And one of the ways to use methotrexate is to split the dose that increases the bioavailability or increase it to subcutaneous. And oral methotrexate going from 15 to 20 makes no difference at all, but injectable methotrexate makes a big difference in the bioavailability. And so I always preach here to use that. People who have all kinds of methotrexate complications and toxicity, for mucosal toxicity for oral ulcers, in fact, folic acid does not work for oral sores. What works is vitamin A. Very interesting. There is this particular paper which showed that 8,000 units of vitamin A, 70% effective in reducing methotrexate oral toxicity like ulcers. Neurotoxicity, patients complain that, oh, I get malaise and I feel very fatigued and this and that and etc. And dextromethorphan is available here as guaifenesin, but dextromethorphan with and after methotrexate, the dose of the day they take methotrexate, if you give them dextromethorphan and BID the next day, their neurotoxicity or fatigue and cognitive symptom and this and that, etc., gets dramatically better. So just a few quick slides about combination therapy. TNF inhibitors can be combined with IL-12/23 inhibitor. Now, I'm again well aware that in India, it's difficult to get one biologic, let alone getting two biologics. It's also difficult in the US to do that, but there are these several interesting papers about combination biologic treatment. Tacrolimus, effective in refractory psoriatic arthritis, and then therapeutic depletion of myeloid lineage leukocyte by adsorptive apheresis. I thought, oh my God, who does these kind of things? And intra-articular TNF in patients who have got one joint out of proportion to others. So there are several drugs that rarely used in psoriatic arthritis. I have said, and these drugs are on the horizon. Guselkumab is already approved. Tildrakizumab, risankizumab is not yet available for psoriatic arthritis. And I said, IL-6 inhibitor, rituximab, I don't use them in psoriatic arthritis, but think whether if everything fails, is this really seronegative RA? Cyclosporin, tacrolimus, bisphosphonates, it's SAPHO, intra-articular TNF, and soon to be available these three JAK inhibitors. All of them are JAK1 inhibitor and bimekizumab. And then in future, there will be these oral molecules, ROR gamma T inhibitors. GM-CSF is not oral, and TYK2 inhibitor, there was a phase 2 study we completed and was presented at the ACR. So last two slides. Difficult to treat psoriatic arthritis. Rethink the diagnosis, psoriatic arthritis that doesn't respond to your best treatment. Pain and damage mandates referral and team approach. Unsure of pain and problem, get medical imaging. There are 10 drugs that we haven't tried that you may not have tried. Methotrexate, we have to optimize it, split and inject it, know when to quit it. Don't be handcuffed by the safety limitations and use that vitamin A and other things if patients are getting side effects. Wise therapeutic deselection, deal with depression, central sensitization, fibromyalgia, obesity, and manage expectations and ask the patient which problem you want to fix. So here is the patient that I told you first, which was sent to me by my fellow. So I asked my fellow, have you tried methotrexate? She said, yes, of course I've tried methotrexate, cause transaminases and AST, ALT. What about x-rays? There were no erosions, only joint space narrowing. So any fibromyalgia element? And she said no fibromyalgia. So I thought, yeah, I agree with psoriatic arthritis, but I think it's mildly active. There are 2 or 3 swollen joints. And I mean, why are you trying so desperate trying to get rid of it? Yes, he has got some problem, but it's non-erosive. You have very, very well treated. So my advice was, what exactly are his goals? And have a frank and honest discussion with this patient. Enough trials of biologics, stop biologics, realistic expectation, and you need to probably use more intra-articular corticosteroids, non-steroidal gabapentin, and hand function if he has got problems with this. And will this progress? I said, very unlikely. You have treated him with all these biologics, all these years, there are no erosions, no joint space narrowing. So this, of course, in India will be very different because they may not get all these biologics and they would have severe erosion, severe joint space narrowing, and significant damage. But there again, we need to have this kind of honest discussion as to what we can do with the given circumstances. I end with this quote: the role of the physician is to cure a few, to help most, but to comfort all. And I'll leave you with another picture of my university. We have our campus up on the hill, and we have got another campus next to the river down the hill. And we have these very fancy trams, aerial trams, which go up and down the hill. You're all welcome to come and visit me sometime in Portland, Oregon, and I'll take you on these trams. Thank you very much. And I will stop sharing my slides and I'll take any questions that you may have.
Thank you, Dr. Deoda, for that brilliant exposition on psoriatic arthritis. Shall I just start off with a comment? One of the things which was very interesting is managing the expectations of the patient, as you exemplified in the case you presented. And many times we end up doing it by changing drugs or changing biologicals rather than it's managing expectations. And just one more point I would like to mention to you about that situation in India is we have an unregulated biological market, and hence we do face its consequences. And this is one of the common discussions in our rheumatology forums. So that's 2 points I would like to make. And do you have a point on how do you manage active psoriatic arthritis in a pregnant lady, or how would you approach that?
Yeah, so certolizumab pegol would be the drug that I would be using, because certolizumab, as you know, does not cross the placenta. Sulfasalazine would be, I mean, if she doesn't really need that, sulfasalazine, low dose prednisone, those are other drugs that I might use. Plaquenil is not a very good drug, but we have used that in the past also. So plaquenil, sulfasalazine, low dose prednisone, and if they need a biologic, I would go to certolizumab, because without, and I don't know whether certolizumab is available in India, but it's,
No, no.
since it doesn't have the FC receptor, but doesn't have the FC portion, it doesn't cross the placenta. I didn't get your second point that you said. The first point you said was that you're telling me about two situations in India. You said there is some market.
The biological market is unregulated in India. So an orthopedician or unregulated. So
unregulated. Oh,
so
I
anybody
see.
can prescribe it. So that's one of the common debates in rheumatology circles, which we
yeah.
are looking at it now after the arrival of tofacitinib, which is cheaper.
Well, it's not different in the US. Anybody can prescribe biologics. So even the primary care doctor in the US can prescribe a biologic. It's not regulated. It's not that rheumatologists are required to prescribe biologic. Another interesting thing is places where there is significant large amount of private practice. So I'll give you an example of Los Angeles. There, because it is a private practice very similar to India, and people go from one private practitioner to the other, managing patient expectation is not done, and you want to show that you are better than the other competitor. And so they keep on changing. It's amazing how different it is when I go to talk to my friends in Los Angeles and what happens in Portland. It reminds me of India, how people kind of jump from one doctor to the other, and the other doctor has to give something different because the previous doctor gave you that, and that just causes a problem. And nobody tries to really manage expectations and say that, I think this is the best you are going to get. I mean, rather than you will otherwise just remain very, very unhappy with your situation.
Shall I just go to a question by Dr. Meha Sharma? She has a psoriatic arthritis patient which failed combination DMARDs, adalimumab, and secukinumab. That's available biologicals in India now, and continues to have active arthritis along with enthesitis and fibromyalgic symptoms. Would you consider starting tofacitinib?
Yes, but I mean, before I again jump onto that, I want to know how many swollen joints. I liberally use joint injections, corticosteroid injections. If there are 2-3 joints which are significantly painful, I would inject them with corticosteroid, number one. And I want to know whether it's a primary failure or a secondary failure, because finally, even in the US, we have got limited drugs available, and I'm pretty conservative. If the biologic, you said adalimumab failed, but then or one of the drugs you said anti-TNF failed, I would, if it is a secondary failure, I would go to another anti-TNF failure, another anti-TNF before jumping to tofacitinib. But the answer is yes, tofacitinib is a very good drug, and definitely I would try that. But rather than jumping the class, if somebody has a secondary failure, I would try another drug in the same class, and I would use joint injections more liberally.
So there's a question by Dr. Malavia. Name of the drug to improve methotrexate intolerance.
Oh yeah, so guaifenesin. So actually, it is a dextromethorphan. Guaifenesin is the one that it is a trade name, I think. Dextromethorphan is the drug, and I'll pull up my slide later on. But dextromethorphan is a drug that is available, and you give it the day of their. So this is for patients who have got methotrexate induced fatigue and tired and that kind of stuff. The day of methotrexate, and then BID on the next day. Dextromethorphan. And vitamin A was the one which I suggested for oral ulcers.
Dr. Deodhar, I'll just take the last question. There are many more questions. Would it be okay we send it to questions to you by mail and
Absolutely.
get it prepared? Yeah, thanks for that.
Yes.
The last question is, what is the treatment of choice for dactylitis? Your treatment of choice for dactylitis?
That's a difficult one. I have injected dactylitis in the past, and there again it's very painful to the patient, so I have given up on dactylitis. Biologics are not bad at all for dactylitis. There are studies. So IL-17 inhibitors I find probably better than TNF inhibitors when it comes to dactylitis, mostly because part of dactylitis is also enthesitis. TNF inhibitors would be my first choice, but then IL-17 inhibitors I would quickly jump if dactylitis is causing a significant problem. Several times patients might have dactylitis, which is chronic dactylitis, which looks swollen, but the pain goes away. And I don't really, my expectation, I reduce my expectation and I tell them, this is it. Not, it's not hurting you, that's fine. It is swollen, end of the story. I'm not going to give you, you're already on a drug. I have done as best as I can, and I'm going to leave it at that. So I'm going to manage their expectation and my own expectation. But acute dactylitis is very painful. Chronic dactylitis, it looks swollen, remains swollen, and it stays like that for months. And I don't really get too worried about it as long as they're on some biologics so that they don't really cause structural damage to that toe or that finger.
Thank you very much, Dr. Deodar, for your talk and the excellent replies we got for our queries. And we
Thank
hope to
you.
get, we'll send you the mail for the rest of the questions, if you don't mind.
Thank you. Thank you. Thank you
Thank
very
you
much.
very
And
much.
best of luck and
Thank
great
you.
cases. Yeah, thank you. Bye-bye.
Thank you. Bye. Hand over to Dr. Gangaratna for the rest of the cases now.
A very good morning to all of you. I thank the organizers for giving me this wonderful opportunity, and it gives me immense pleasure to introduce three eminent rheumatologists who will be presenting very interesting and complicated psoriatic arthritis cases. Dr. Abhishek Patil, he is the consultant rheumatologist at Manipam Hospital, Bangalore. Dr. Neena Chitnis, consultant rheumatologist at Leelavati Hospital, Mumbai. And Dr. Soumya Jain, rheumatologist from Saranpur. The first case will be from Dr. Abhishek Patil. Over to you, Dr. Abhishek.
Thank you, ma'am. At the outset, I'd like to thank the organizers for providing me the opportunity and also for moderator for fine-tuning my presentation. Next slide. This is a young male IT professional from Bangalore. He is suffering from spondyloarthritis for nearly 1.5 decades. And he was managed by my senior colleague. And I was involved in his care only March of this year. At the outset in 2006, I was diagnosed with spondyloarthritis. He had a very high disease activity, suboptimal response to sulfasalazine and anti-inflammatory drugs. So he was given infliximab between 2009 to 12. He received about 14 infusions or so, and thereafter he lost to follow-up. 2 years later, he returned with a much badder disease and also requiring hip replacement. So he was initiated on once a week etanercept, and slowly it was tapered off to once monthly dose, which we often do in most of our patients. So once the disease response is there, we try to de-escalate the biologicals. There was no documentation of AN at baseline. Next slide. For the first time, he presented to our hospital in March of 2020. He had a fever, cough for 3-5 days, and there was no scare of corona at that point. So he was confidently given azithromycin by a physician outside. He did not improve. On the contrary, he continued to have increased breathlessness, palpitation, and then he developed chest pain, and he was brought to emergency. And in the all along, his disease activity was quite. Next slide, please. In the emergency, he was noted to have a hypotension, a low voltage ECG complexes, and he was also noted to have a large pericardial effusion with impending cardiac tamponade. So the cardiologist went ahead and did a pericardiocentesis, and the analysis of the fluid are on your screen. It's exudative fluid, basically free of any infections. Next slide, please. Despite of this, he did improve, breathlessness improved, but he still continued to have high-grade fever, documented to about 101 degree, and then chest pain. So a pulmonologist was involved in his care on second or third day. They got a CT scan done, And CT scan confirmed what the echo had shown. It was showing a large pericardial effusion. In addition, he was having large left pleural effusion and a moderate right pleural effusion. But the underlying lung parenchyma was perfectly normal. Next slide. So this is what his labs, basic lab work was normal, liver, kidney functions, complete blood counts, tropi, everything was negative, urine was normal. Apart from a high inflammatory markers, as you can see on the screen, the pulmonary medicine team went ahead with pleural tapping as well as pleural biopsy also. But again, TB expert was negative, and cultures from the pleural fluid were negative. All along, he was also worked up for other unusual viral infections. Everything came back negative. So he was continued on treatment with antibiotics and antivirals, but his fever did not subside. Next slide. And that's where I was called in. And to summarize what I told, it's just a young male with spondyloarthritis previously treated with biologicals, that is TNF blockers, initially infliximab, and due to cost concerns, later etanercept and once a monthly dose, who presented with the acute pleuropericardial effusion for 7-8 days. And it wasn't responding to antibiotics or antivirals. So I considered, like my previous two colleagues, that I considered infective, whether it's bacterial or viral, to be the first possibility, later tuberculosis. But I did also consider whether it could be a drug-induced phenomena. Next slide. So I ordered immunology workup, and as you can see, the ANA was positive in a very high titer. Anti-dsDNA by ELISA was also strongly positive with the normal complements. Next slide, please. So I entertained the possibility of a TNA-induced lupus, although I never saw a patient presenting so late because of this problem. So I put him on a low dose of steroids, prednisolone 50 mg per day, and HCQ was started at 300 mg per day. And within 2-3 days, his fever crashed, and his chest pain, breathlessness, everything was stable, and we were able to discharge him on a stable state over home. He later came up to me after a month's time. At that time, he did not have any chest complaints. The X-ray was normal, but now the disease has again flared up. So he was in a lot of back pain and stiffness. I discussed this case with my senior colleague who was handling him for so far, and also with the patients. I explained him the therapeutic options available, and we decided to start him on secukinumab. And I last spoke to him about 2 months ago, and he was doing well with once a monthly secukinumab. Next slide, please. So why did I entertain TNF-induced lupus in this patient was because there's a good temporal relationship from the initiation of drug to development of symptoms, absence of any underlying lung problems, and once the pericardial tamponade was tapped, the repeat echocardiogram showed that it is a perfectly normal heart that he had, and all along there was a negative workup for infections. It was quite thoroughly worked up, including a pleural biopsy, and he had such a prompt response to low dose of steroids. But there were two things which were pinching me. One thing was, if it was TNF-induced lupus, why did it take such a long time to develop this complication? Particularly was on etanercept for 6 years. And I did not find any other typical cutaneous or joint manifestation which are associated with the lupus. Next slide, please. So before we address them, let us go through why TNF blockers should cause lupus-like reactions at all. We all know that there is a inverse correlation between TNF and interferon. So whenever TNF goes up, it tries to, it blocks the action of plasmatic dendritic cells and thus reduce the interferon production. So whenever you have this break taken off by TNF blockers, then you have unregulated plasma dendritic cells, and which will secrete excess of interferon. And we all know that a hyperinterferon state is a fertile ground for lupus to develop. Also, it alters the T helper cell profile. And two other possible explanation could be because TNF blockers are potent immunosuppressives, you might have an increased risk of infections, and that in turn may lead to polyclonal activation of B cells. Also in RA, there are studies which have shown that there is increase in apoptotic antigens after the use of infliximab, and such a mechanism could exist for other TNF blockers also. Next slide, please. The incidence, I dug into the literature, and what I could find that the actual incidence of anti-TNF induced lupus maybe is about 0.1 to 0.2%, and it's a little higher for infliximab and least for adalimumab. I did find few case reports of golimumab, but I can't put it into a figure as of now. The maximum interval between the initiation of infliximab and the onset of symptoms, lupus-like symptoms, what I could understand from the literature was 4 years. But I thought if it is 4 years, why can't it also be 6 years? Next case, the next slide. Just a brief slide highlighting what are the typical clinical feature of TNF-induced lupus. This was a work of Michelle and her colleagues, and what they found that described 33 patients with various TNF blockers who developed lupus-like features. And unlike other typical drug-induced lupus, for example, hydralazine, procainamide, what they found that these patients had a higher proportion of cutaneous manifestation, higher proportion of arthritis, increased incidence of ANA, and very particularly dsDNA antibodies were positive in many of these patients with the low complements. And also neurological and nephrological involvement was often noted in these patients. Next slide. There are no definitive criteria to diagnose TNF-induced lupus, but Bandit et al. They and colleagues, they talk about these steps, that there should be a good temporal relationship between the onset of symptoms and initiation of drug. The patient should have at least one ACR clinical and one serological criteria. And they importantly note that other antibodies like anti-Rho antibodies, centromere, or even RNP or Smith are very rare in TNF-induced lupus, although dsDNA are quite frequently found. And there should be a prompt resolution with the initiation of withdrawal of the drug. So all these things were matching in our patients. Next slide. So just one slide, whether seroconversion to be monitored. Seroconversion means whether those patients who are ANA, dsDNA negative for non-lupus conditions, when we initiate them on TNF blockers, whether they develop ANA through the line, through the time. Including the landmark trials for infliximab in rheumatoid, that is ATTRACT and ASPIRE trials, most trials have reported such occurrence, and they've reported that it occurs in about 40-50% on an average. But very rarely that we see that these antibodies lead to TNF-induced lupus, because TNF-induced lupus itself is quite rare. Next slide, please. So this is highlighted by this case series, case review actually, which describes various TNF-induced lupus which have been described in literature. So you can see that the ANA antibodies over a period of 6 months to 1 year can develop in as high as 70% of patients who are being treated with TNF blockers in non-lupus conditions. But the actual incidence on the right side, you can see that actual incidence of TNF-induced lupus is pretty rare. Next slide. So I would like to give a take-home message from my presentation that drug-induced lupus is very rare with use of TNF inhibitors, but seroconversion is very common. For a clinician, a high index of suspicion is very critical. The third point, whether I should have used adalimumab in my patient, is that whether I should have switched to another TNF inhibitor, or I should have chosen a separate class of drug like secukinumab altogether, is for open debate. There are more and more series now coming up that if you switch from one TNF blocker to another TNF blocker, the chances of recurrence of this autoimmune phenomena is very low. But as I told this, I discussed this with the patient as well as my senior colleague, and all of us were more in for secukinumab, and I'm glad that it worked for my patient. Next slide. So that brings me to the next slide, Akshat. Thank you. So I'm very grateful for all you to joining in.
Good afternoon, everyone. Going to my case. Next slide, please. So my case is of a 40-year-old male. He was a mechanic by profession, hailing from Uttar Pradesh. He was admitted in a hospital with history of asymmetrical polyarthritis since 1 year. Actually, he was admitted under an orthopedician for a suspected fracture of phalanx, and he was going to be operated. In view of the asymmetrical polyarthritis, a rheumatology reference was given. On examination, he had synovitis in the left wrist, left first MCP and PIP, bilateral ankles, and bilateral MTPs. He also had extensive palmoplantar lesions. And for the pain, he only had been taking anti-inflammatories on and off and some alternative therapies like Ayurvedic and homeopathic. Next slide, please. So the dermatologist confirmed the diagnosis of palmoplantar psoriasis. We planned to start methotrexate after the investigations. However, his routine labs revealed an anti-HCV positive status. Now, honestly, I do not do HbSAg and anti-HCV as a routine in all my patients before starting methotrexate. However, this anti-HCV had been done as a part of his pre-operative workup and it came to be positive. Hence, a gastroenterologist was involved. Next slide, please. Now, the further investigations, his viral load was very high, about 18 million copies. The genotype was 3. His liver function tests were normal. The USG abdomen was normal. He had mild anemia. Rest hemogram was normal. The CRP was very high, 157, and the ESR was 80. Next slide, please. Now, seeing the above investigations, starting him on antiviral therapy became the priority. So, on discussion with the gastroenterologist, he was started on directly acting antiviral therapy, a combination tablet of sobusvir and dactylasvir. It contains sobusvir 400 mg and dactylasvir 60 mg. Coming to the treatment of his arthritis, the conventional DMARDs, methotrexate and leflunomide, had to be avoided due to the possible hepatotoxicity. This patient was not affording TNF blockers. We started him on cyclosporin 100 mg per day, and with monitoring of his renal function test, it was increased to 150 mg per day. He also needed tablet diclofenac 75 mg twice a day, in spite of which he was quite much in pain and also needed to be given steroids between 5 to 15 mg on and off. Next slide, please. In view of his active arthritis, we discussed with the gastroenterologist and started the patient on sulfasalazine. However, he had a severe allergic reaction and sulfasalazine needed to be stopped. Next slide, please. Now, the patient continued to have very active arthritis as well as psoriasis. In fact, it worsened during his treatment, and he kept on telling us that I was much better before I started this medication. He needed regular anti-inflammatories. We also changed from one anti-inflammatory to another, but he still remained quite active. As I said, he needed steroids also on and off. And during treatment, he developed mild anemia, mild thrombocytopenia while he was on the antivirals. Next slide, please. So here our dilemmas were, he had no relief with cyclosporin, needed full dose anti-inflammatories. Methotrexate, leflunomide, sulfasalazine could not be given, and he was not at all affording for TNF blockers. Next slide, please. So somehow we just pushed on the 12 weeks. So he completed antiviral therapy of 12 weeks. At the end of treatment, his HCV viral load was less than 15. He continued to have active arthritis. At this point, I had a discussion with the gastroenterologist about starting the patient on methotrexate. However, he asked us to stop for 3 months, like withhold methotrexate for 3 months. After 3 months, we again got a viral load, which was still negative. His LFTs were normal. Hence, next slide, please. Hence, we went ahead with a fibroscan. When the fibroscan came normal, we decided to start methotrexate with caution and regular liver function test monitoring. Next slide, please. Next slide, please. So within 3 months of methotrexate therapy, the patient was off anti-inflammatories and steroids. He was on methotrexate 15 milligram per week and cyclosporin 100 milligram per day. His liver function test continued to be normal. In fact, his hemoglobin also increased to 12 and he was doing perfectly well. Next slide, please. So to summarize, we had a patient of psoriatic arthritis with concomitant HCV who was not affording for biological therapy. He had inadequate response to cyclosporin. Though methotrexate ideally should be avoided, we started it with caution. Next slide, please. So going through the review of literature, in patients who have psoriatic arthritis with concomitant hepatitis C, cyclosporin is the drug of choice. It is not only safe, but it also has antiviral properties and helps in the treatment of hepatitis C. Methotrexate and leflunomide are contraindicated in all child classes. Sulfasalazine can be given in class A, but it is best avoided in class B and C. Next slide, please. Coming to TNF blockers are generally safe and do not cause reactivation of the hepatitis C. In fact, inhibiting TNF may be beneficial in HCV. It has been shown that TNF alpha is engaged in liver fibrosis by inducing apoptotic pathways. In fact, there are small studies in which etanercept has been added to interferon and ribavirin to help treatment of hepatitis C, and it has been shown to be beneficial. However, there are no long-term studies about the safety. So after treatment, once the HCV viral load is undetectable, we can go ahead with a fibroscan and add methotrexate with regular monitoring of the liver function test. Studies have shown that methotrexate is safe and does not cause reactivation of the hepatitis C. Next slide, please. Now coming to the treatment of the hepatitis C when the patients have psoriasis. The earlier therapies, which were interferon-based therapies, had lot of side effects. They were known to in fact trigger and worsen psoriasis and psoriatic arthritis. Hence, in such patients, the directly acting antivirals are more preferred. So in India, we get a combination of sofosbuvir and dactalvir.
Stiffness was there. Next slide. We were stuck there, and dilemma was there what to do despite being on giving treatment with methotrexate, sulfasalazine. Psoriasis lesions were precipitating, patient arthralgia is increasing. So drilling more into the history raised suspicion of HIV, which came out to be positive by CART test and later on confirmed by Western blot. Viral load was 80,000 copies per ml and CD4 count was 320 cells. Next slide. Now we reach to a conclusion that patient is probably having HIV with HLA-B27 reactive arthritis, because we had a triad of arthritis, urethritis, conjunctivitis with coexisting psoriatic arthritis in view of asymmetric lower limb oligoarthritis and dactylitis. All drugs except NSAIDs and topical steroids were withdrawn and patient was referred to ART center. Now he is doing well on heart alone with no DMRDs, no immunosuppressants given. Only topical therapy and heart treatment is going on. Next slide, please. So, point of discussion is Articular syndromes that have been described in association with HIV include HIV per se itself associated arthropathy, seronegative spondarthropathies, reactive arthritis, psoriatic arthritis, which is very common, undifferentiated SPA, rheumatoid arthritis, and painful articular syndrome. Next slide. HIV positive have higher risk of developing rheumatic disease. This can occur at any stage of the disease, and there are again challenges in the management of inflammatory arthritis with HIV. Next slide. So, slide on psoriatic arthritis with HIV. Along with an increased occurrence, HIV infected patient with psoriasis have more severe and persistent skin lesions with guttate and inverse and erythrodermic type, the most common one. More severe and deforming erosive arthropathy is present in coexisting HIV patients, and they are generally refractory to conventional treatment. This point I'm again highlighting because patient is not responding to the conventional treatment. So we digged into the history and found it to be immunocompromised status. Abrupt onset and rapid progression, and number of joints affected tends to increase with time. Next slide. And since he had two types of arthritis, most typical presentation of reactive arthritis, that of seronegative peripheral oligoarthritis, predominantly involving the lower extremities, usually accompanied by enthesitis. Mucocutaneous features are common, classically keratoderma bleromogicum and sarcinate balanitis. Now, one thing interesting is HLA-B27 is found in 80 to 90% of Caucasians with HIV-associated reactive arthritis. While contrary, studies of Africans with HIV-associated reactive arthritis have found nearly all to be HLA-B27 negative. Next slide. So, the take-home message, my conclusion is NSAID remains the first-line treatment for HIV-associated arthritis. DMRDs are again rarely required due to self-limited nature of the disease. You treat the HIV, you build up the immunocompromised state up, and the disease is treated itself. This is in contrast with other forms of arthropathy found in association with HIV infection, arthritis of undifferentiated SPA, and indeed all spondyloarthropathy can improve significantly with highly active antiretroviral treatment alone. Next slide. In case of unresponsive arthritis, the take-home message is always consider immunocompromised state like HIV. Coexistence of two different arthritides can be seen, though very rare, in a same individual. HLA-B27 positivity favors more of reactive arthritis than of psoriatic arthritis. HIV arthropathy responds well to heart rather than initiating DMRDs and steroids. Thank you.
Thank you, all the speakers, for your wonderful cases. I would like to make some remarks on this occasion. Firstly, it is about the baseline screening for ANA when it comes for starting anti-TNF. In West, most of the guidelines do recommend, and it is done in practice. I have had a case of anti-TNF related sinusitis similar to Dr. Abhishek's. After 5 years of being on anti-TNF, my work was presented in British Society Rheumatology 2017. At the time, it was like his literature review. It is seroconversion, but actual lupus is very rare. But doing baseline AN screening is always helpful, and it would be helpful for future data. If actual patients, if patients do develop SLE or lupus. Coming to the serositis dose, the 15 milligram, that was enough for his case. That was lucky. The patient was discharged within 5 days. In our case, the steroid requirement was much higher, so we have to be mindful. And when I checked with Dr. Abhishek, he felt that there was worry of coexisting or possible underlying TB, so they started on the lowest possible, which could be practical here in Indian scenario. So coming to other two cases of Dr. Neena and Dr. Somya, it reminds us how important it is to do the baseline. Again, go back to our basics and do the baseline infection screen, including hepatitis B, C, HIV before starting DMARDs, ideally, or if not, when we suspect things when they are not going as we expect them to go. viral load needs to be monitored. So when patients are on hepatitis C screening, they have the monthly treatment. We have to repeat the viral load at the end of 3 months, and also at least after 3 months of being on the DMARDs, just to ensure that there is sustained viral load, which is not detectable. And finally, we should not forget about coexistent two types of arthritis, be it psoriasis and gout in the past presentations, or HIV and reactive arthritis. So in the interest of time, I'm requested to move ahead. So we will answer all the questions as much as possible through chat or through email. So I would request the audience to bear with me. The certificates will be available in the afternoon after 1 o'clock till evening today. Once again, thank you for the wonderful cases, and thank you, the organizers. Thank you. Over to you, sir.
It's my pleasure to introduce a good friend of mine, Dr. Ramesh Joyce, who after his training in rheumatology in England is a senior consultant rheumatologist at Vikram Hospital, Bangalore, and he's a past secretary of Indian Rheumatology Association Karnataka chapter. He has more than 30 index publications in national and international journals. Over to you, Dr. Ramesh.
Thank you, sir. So at the outset, I'd like to thank Dr. Vinod Ravindran, Ajit Nalwade, Mohit, and all the organizers of World Rheumatology Forum. It's been a fantastic experience for me to listen to those lovely cases that my colleagues have been presenting. So my job today is to see what is holistic care for psoriatic arthritis in India. And to do that, what I'm going to do is to see what we remember Professor Atul Diodar saying that there's a lot to be published from India or from the Asian countries. So what I've tried to do is to amalgamate our own publications from India and see how best can we utilize that in everyday practice to give holistic care for patients with psoriatic arthritis. We have been told by the experts that treat to target is very important to sustain either a remission or low disease activity in patients with psoriatic arthritis, although till today nobody knows what is the best definition for remission in psoriatic arthritis and what would be the ideal, effective, low-cost regimens to achieve this. So we have to understand that one of the biggest problems we face is so that psoriatic arthritis is an undiagnosed disease, and this poor diagnosis can come from various places. You look at dermatology clinics, it has been shown from a study in Dublin that 29% of psoriatic patients in dermatology clinics had undiagnosed arthritis. PREPARE study was a large multi-center study across Europe and North America involving 34 dermatology centers, and it showed that 1/3 of patients seen in these places had undiagnosed psoriatic arthritis. Labeling patients as psoriatic arthritis, rheumatologists could also be making mistakes. We could confuse psoriasis with other skin diseases. From a patient perspective with psoriasis, those who go to the dermatology OPDs may not consider it important to forthrightly tell their musculoskeletal symptoms to skin doctors because it may not be their domain. And also the fact that particular disease can easily be ignored. And then you come to the community, orthopedics or physicians are more familiar with polyarticular rheumatoid as opposed to polyarticular psoriasis, psoriatic arthritis, or oligoarticular psoriatic arthritis. So hence more likely that psoriatic arthritis is going to be missed. And obviously, needless to say, we are all aware that psoriatic arthritis presents in different domains. So that makes diagnosis even more complicated and easy to be missed. One of the dreaded consequences of delayed diagnosis of psoriatic arthritis, even if the delay is within just 6 months, barely 6 months, is arthritis mutilans. As shown in this study, that the incidence of arthritis mutilans was the highest when when there was a delay in diagnosis for more than 6 months. Needless to say that there were other things like erosion, sacroiliitis, so on and so forth. So how do we optimize care for psoriatic patients in India? That is the question. Holistic care for our patients. One of the most important aspects of this is crosstalk with dermatologists. So at a regional level, local level, doing meetings with dermatologists, or if feasible, doing combined clinics with dermatologists could be one of the answers. So the dermatologist and rheumatologist both have an occasion to diagnose patients with psoriasis and inflammatory arthritis, depending on what presents first to their respective outpatients, optimizing control of cutaneous disease and articular disease, and screening for at-risk population, and ensuring compliance and taking care of other issues. So in order to achieve holistic care, there are many India-specific unmet needs, and Professor Atul Diodar did highlight some of these things. So you might find that there are a couple of slides that my talk has an overlap with Professor Diodar's. I didn't know he was going to show those. So please bear with me. So we all agree that there are a lot of unmet needs when it comes to us giving good care to our patients. One is that of lack of trained professionals, poor medical education. Even now, rheumatology is not part of the main curriculum of medical students. Access to healthcare, we've already spoken. We have already spoken about challenges posed by alternative systems of medicine, late diagnosis, huge patient load in our OPDs, self-paying versus medical insurance, doctor shopping, doctor Google are peculiarities that are restricted mostly to India, and a lack of a very effective patient support group who can be a great voice for patients' unmet needs. So whatever holistic care we plan to do should be centered around patients. So a patient-centric approach is important, listening to patient expectations and ensuring adherence in order to enhance effectiveness of therapy. So a shared decision making is where we should shift our focus in future. So when it comes to India-centric holistic care, the next part of my talk is going to be focused on two main domains. One is about what is the local disease burden we are seeing and what are the therapeutics that might work for us. So I will be leaving out biologics completely from my talk because we all have debated enough about the cost of biologics. So the Karnataka psoriatic arthritis cohort was a prospective open-labeled cohort which was across 17 rheumatology centers in Karnataka, where daily life care was mirrored in the data, and data was collected on psoriatic patients, successive psoriatic arthritis patients who came to the OPD. And it was shown that polyarticular disease and oligoarticular disease formed the bulk in this tertiary care centers, which all of these 17 centers were. And majority of the patients, if you see, or nearly 50% of the patients had high and moderate to high disease activity. So the message you get from an assessment of the Karnataka psoriatic arthritis cohort was you had a patient cohort which had polygoarticular and oligoarticular disease predominantly with moderate to high disease activity. And surprisingly, we had bulk of patients with mild psoriasis, probably because there's a referral bias here. Similar disease burden has been enumerated by other publications from India. The first one, Ramesh Kumar et al., is a part of Aman Sharma's group from Chandigarh, a cohort of 1,000 odd patients where only about psoriasis patients, where only about 8.7% of patients had arthritis. Majority of these were polyarthritis like our study, whereas equal numbers had spondyloarthritis, which we did not see. And another cohort from, this one is from Kashmir, which is a dermatology cohort, which looked at around 150 patients where symmetrical polyarthritis was the commonest presentation. So this enumerates whatever data we have as far as disease burden in the country is concerned. So the therapeutics is challenging without the use of biologics to achieve low disease activity or remission, as has been enumerated by most recommendations. So when it comes to the therapeutic challenge, what have we been given so far? GRAPPA was one of the earliest recommendations that came up, and all of us are familiar with this. This was published in 2016, although a lot of this is very difficult for us to follow. And then came the ACR recommendations. Now, if ACR recommendations from 2018, if I don't know how many of you have studied this whole document, it's as complex as this cartoon that I have shown here. The ACR recommendations is a fantastic document, but then a lot of it is bound by legalities. So if you read the ACR recommendations, you will find a lot of legal language in it, and it's not easy to comprehend and put it into everyday practice. Then came EULAR, which is the latest one, the latest revision to the previous recommendations. And the phase one was to start either of the one DMARDs. And if there was no response within 3 months, was to switch over to a biologic DMARD. And that's a bit tough when it comes to us doing it in India. And there are a whole lot of other things in the flow chart, which I will not go into in detail. So what has been the practical utility of these clinical guidelines? The clinical guidelines have been made keeping in mind the availability of biologics freehand as even first-line therapy. So it suits resource-rich countries. And if you look at even the first recommendation of the treatment-naive psoriatic arthritis patients, one of the recommendation is to start off straight away on TNF inhibitors if patients had poor prognostic features or severe disease, which is next to impossible. None of these recommendations have addressed the issue of combination of DMARDs. Now, combination of DMARDs has not been addressed by these recommendations, mainly because of lack of evidence. India has a lot of biosimilars and intended copies. None of these have been studied in psoriatic arthritis. And the goalpost of remission, we all know, is very difficult to achieve with non-biologic therapies, especially those with severe and moderate to severe disease. So these are the challenges that lay in front of us. So this was shown by, to address this situation in resource poor settings, this slide was also shown by Professor Deodar, where they tried to see if they could come up with some recommendations for resource poor settings. And unfortunately, due to lack of evidence, they could not come up with a management plan for patients in resource poor settings. And Aman Sharma was also part of this study group. And they stuck to the point that a combination of GRAPPA and EULAR recommendations may best be followed where possible. So let's look at what can we do in everyday clinical practice. And when we look at it, the first and the foremost, we all knew that a lot has been debated about poor evidence for methotrexate in psoriatic arthritis, although this is one of the most widely used drugs. So one of the best evidence was recently published by our own Nizam's group by Professor Lisa Rajshekar's team with Shravan Kumar as the first author, an open label prospective study of methotrexate, 73 patients, and it was shown that major DAPSA was achieved in nearly 59% of the patients, and a moderate response was achieved in a majority of the patients, 74, but good response was achieved in a minority of patients. Similarly, minimal disease activity was achieved in nearly 60% of patients. PASI response 75 was also achieved in 3/4 of patients. So methotrexate was a good option. And this is one of the very good studies which has been now been quoted widely across international literature on methotrexate for psoriatic arthritis. Uma Karjigi presented an abstract from Karnataka psoriatic arthritis cohort on the use of methotrexate for psoriatic arthritis. And we had similar results from like what was seen in the Nizam's group, and nearly 60% of our patients were on methotrexate monotherapy, and DAPSA response of less than 14, which is moderate response, was seen in nearly half of the patients. And most of these patients were on more than 15 milligrams of methotrexate. What about combination therapy in Indian patients? Can we try methotrexate plus leflunomide? This was also presented by Uma in IRACON last year at Pondicherry. 378 consecutive patients of psoriatic arthritis from the Karnataka Psoriatic Arthritis Register, which looked at methotrexate plus leflunomide versus methotrexate alone. It was shown that methotrexate was a very good drug. However, the conclusion was that adding leflunomide for patients who were already on methotrexate did not give added benefits in our cohort of patients with psoriatic arthritis. So those are the numbers for those of you who are interested. One other cheap drug that is available for us is apremilast. The Palace trials showed that apremilast was effective in biologically naive, biologically experienced, and biologic failures. However, there are some issues, diarrhea in a significant proportion of patients, unknown effect on structural progression, and less effective than biologics. So we tried to answer this question about, and from the Karnataka psoriatic arthritis cohort, if apremilast could be used as the first choice DMARD in combination with methotrexate in patients with psoriasis or psoriatic arthritis. We had three groups of patients: those who were in combo with leflunomide, those who were in combo with sulfasalazine, and those who were in combo with apremilast. So this exactly mirrors everyday clinical practice. And we showed that whatever drug you used, as far as arthritis was concerned, it did not make a big difference combining them. The efficacy was the same. However, what I have highlighted here in yellow, that for psoriasis, the combination of methotrexate and apremilast was probably the best compared to the other two drug combination. However, there was good, moderate efficacy across all the three combinations. So this is a good therapeutic choice for those patients with moderate to severe disease. Monitoring disease activity is a challenge. We looked at to see if HAC-DI, or the Indian version, that is the Pune version of HAC, can it be applied in our patients with psoriatic arthritis? And it was shown that HAC could be effectively employed to assess outcomes. And in spite of being on therapy for at least 6 months, half of our patients had moderate to significant disability as assessed by HAC, suggesting that there is still leftover high disease burden in our patients despite 6 months of therapy. The situation in India is now complicated. After DCGI approved tofacitinib for the treatment of psoriatic arthritis in August this year, and just 2 weeks ago, we had a flood of brands coming up. So Vinod Ravindran is going to give a prize at the end of this conference for somebody who names all the available tofacitinib brands that are available in India today. So it's as confusing as that. You can put tofa and anything else after that, and it will suit a local brand. So I thought it might be worthwhile to look at the data of tofacitinib, because now that so much of tofacitinib is available in India and DCGI has given an approval, why don't we look at it? OPAL Broaden and OPAL Beyond were the two studies, phase 3 studies with the original tofacitinib, that was Zelzans. And this was in patients who were conventional DMARD resistant and those who were TNF inadequate responders. And then we also had an adalimumab comparative arm in the OPAL Broaden. And OPAL Balance was an open label extension of these two studies. And what were the conclusions? That in a significant proportion of patients, so tofacitinib therapy met the primary endpoint, which was ACR 20 response, and this was comparable to adalimumab. The response was marginally lesser in TNF inadequate responders, but it did also work. More so, the ACR 20 and 50 responses, and you could not get a very good ACR 70 response in these patients. And the onset of action, it was rapid, and joint symptoms were relieved as early as 2 weeks, and it was sustained in patients. And other domains of psoriatic arthritis did well in comparison to adalimumab, and this was enthesitis as well as dactylitis. However, what is the role of tofacitinib for plaque psoriasis? Because we are trying to look at a common agent to treat both. OPT Compare was a randomized trial which looked at 12-week data, and was shown that tofacitinib 10 mg was found to be 10 mg BID, was found to be non-inferior to etanercept. That is, it was similar to etanercept, but tofacitinib 5 mg BID, what we conventionally use to treat arthritis, was not shown to be non-inferior. In other words, tofacitinib 10 mg BID was a good dose for plaque psoriasis, whereas the conventional doses we use, 5 mg BID, was not a great option. So, however, the 10 mg BID is not licensed for use in arthritis by the DCGI. And also, tofacitinib radiographic progression. The Opal Broaden had a sub-analysis of radiographic outcomes, and it was shown that more than 90% of patients showed radiographic non-progression. However, it is important to note that the overall rate of radiographic non-progression was low across all the patients in the trial. So we still need data on radiographic progression from tofastatinib. And Opal Broaden also showed that Leeds enthesitis index was found to be, the response was better with the 10 mg group rather than the 5 mg group. So skin disease and 10 as well as enthesitis responded to higher doses. One of the problems we have is to sustain patients on treatment, and we stop and restart treatment. So how safe is it to restart, or how effective is it to restart after stopping treatment with tofastatinib? So this OPT retreatment trial was in psoriatic patients, and what it was shown was that tofastatinib could be efficacious after withdrawal and retreatment in at least 60% of the patients, capturing the effect in this particular trial of psoriasis. So I still don't know what is the effective conclusion, because 40% of the patients did not show the same response. Now, I don't know the reasons for this, whether there's any immunological phenomenon that prevents response in all of them, or whether the flare was so bad when the drug was withdrawn, whether the same dose was not effective. But however, there is one Japanese phase 3 trial which was predominantly in psoriasis and a small number of patients with arthritis, which showed that even tofastatinib 5 milligram BID, a lot of the 70% of the patients achieved good response, which was PASI 75. And PGA was also good in tofastatinib 5 milligram group. So the verdict, if you read this Japanese trial, they found a good response with a conventional dose of tofastatinib in patients with bad psoriasis, also in addition to arthritis. So the bottom line is we could use tofastatinib 5 milligram BID, but then if you have somebody with a very bad skin disease, maybe you could use 10 milligram BID with patient's consent for a short period of time, like how we use etanercept 50 milligrams twice in a week, or adalimumab 40 milligrams weekly for those with very severe skin disease. The last part of my talk, I'll just take a couple of minutes extra, Chairperson. One of the important aspects of psoriasis and psoriatic arthritis that is treated is the comorbidities. Psoriatic march is the term that is used these days, and it is seen that those patients with arthritis tend to have more comorbidities than those compared to skin disease alone. And those with skin disease alone have more compared to the general population. And this includes insulin resistance, obesity, cardiovascular events, cerebrovascular events, and metabolic syndrome. So what data do we have from India in this respect? This is going to be my presentation in the last 3 slides. The Karnataka Psoriatic Arthritis Cohort Study published a poster authored by Chanakya as the first author on the prevalence of comorbidities in psoriatic and their arthritis and their impact on disease measures. I've already described the cohort to you. A comprehensive psoriatic comorbidity index was calculated for all the patients who were enrolled, and it was correlated with the disease activity measures, which was PASI, DAPSA, and HAQ-DI. It was shown that patients with comorbidities had significantly longer duration of arthritis than those who did not have. Nearly 40% of our patients with psoriatic arthritis had one or more comorbidities. HAQ-DI was significantly more in patients with comorbidities. And one of the important comorbidities that we saw, the top 3 were hypertension, diabetes, and dyslipidemia. And it's important to see that nearly 40% of psoriatic arthritis patients had comorbidities. We had earlier published from the KRAC study, that is Karnataka Rheumatoid Arthritis Cohort, and we compared the comorbidities between rheumatoid arthritis and psoriatic arthritis. It was shown that the prevalence of hypertension and diabetes was almost the same in both these cohorts, although published literature says that comorbidities are more so in psoriatic patients. And what about other data from India? The first one that I've shown, Ali, is from Mangalore. Metabolic syndrome was seen in about 63% of patients with psoriatic arthritis compared to 33% with psoriasis alone. Aman Sharma's group published again from PGI that metabolic syndrome was more common in Asian Indian patients with psoriatic arthritis, especially those with long-standing disease and active disease. And finally, published from Ramchandra Medical College from Chennai, which looked at an increased prevalence of fatty liver. This is a very important non-alcoholic fatty liver, very important aspect because a lot of our patients go on methotrexate. An increased prevalence of non-alcoholic fatty liver in patients with psoriatic arthritis. It was shown that NAFLD was higher in psoriatic patients and more so in psoriatic arthritis patients. And also those who had more severe NAFLD had more chances of steatosis, NASH, and fibrosis scores. And so obviously we have to be cautious that there's a very high prevalence of non-alcoholic fatty liver disease in our patients, Indian patients, and this was a study from South India. And my last slide, obviously atherosclerosis is another important aspect of its in psoriatic arthritis. And this earlier publication by Ashit Single and group from Chandigarh, which demonstrated that carotid intima media thickness was significantly higher in psoriatic patients compared to controls. And there were a lot of things like flow-mediated dilatation, EPCs, and HDL cholesterol were significantly reduced, and carotid intima media thickness positively correlated with inflammatory markers. And it has been shown that accelerated atherosclerosis and endothelial dysfunction is common in Indian patients with psoriatic arthritis in this small study.
Ramesh, can you wind up?
Yes, sir. This is my last slide. So, so to sum up, what I would say is, so holistic care for psoriatic arthritis amongst Indian patients is challenging. Obviously, not without using biologics, it's not easy. However, with the available options and with available published literature, I've just given you a broad view of what we could be doing with our patients to achieve holistic care in India. Thank you very much.
Thank you, Ramesh, for the well-studied talk. It was very informative and useful for our regular practice. Because we are short of time, Ramesh, we may not take questions now. So whichever questions are coming, we'll email it to you. So we'll be putting it on the WRF website, the answers, questions and the answers. And for the last session, I would invite Dr. Subrat Arya, who's the gold medalist for his DM in rheumatology from STPGI. And now he's a consultant rheumatologist at Dr. Arya's Care and JP Hospital, Noida. Over to you, Subrat.
Okay. Thanks a lot, organizers, for giving me this opportunity. So let's change gears and move on to a different disease. So I'm presenting a case of 26-year-old lady who was diagnosed as SLE with class 3 lupus nephritis in 2015. That point of time, she was treated with cyclophosphamide as per Euro-lupus protocol and was given maintenance in the form of azathioprine. The compliance was not good and treatment was irregular. In July 2017, she had a renal flare in which she had high blood pressure, elevated serum creatinine, and active urinary sediments. She was offered a kidney biopsy, but the patient declined. So she was treated as rapidly progressive glomerulonephritis with methylprednisolone pulse, and cyclophosphamide was initiated as per NIH protocol. In October 2017, she received third dose of cyclophosphamide, after which she developed generalized tonic-clonic seizures with transient weakness of the left side. And after 4 days, she landed up in the emergency department with high-grade fever, recurrent episodes of generalized tonic-clonic seizures, headache, and left-sided hemiplegia. And this point of time, she was admitted in the ward. Next slide, please. So at the time of presentation, she was tachycardic. There was high-grade fever. Her blood pressure was 130/76, but she was on antihypertensive medications. Her CNS examination was remarkable with left-sided hemiplegia with facial palsy, and the left plantar was mute. Other systemic examinations were within normal range. Next slide, please. So in a young lady who has lupus, has active nephritis, and has presented to the emergency with hemiparesis, these were the following differentials which we kept. Either it could be thrombotic CVA, cortical venous thrombosis, IC bleed, and also a possibility of CNS vasculitis and CNS infections were kept. Next slide, please. Yeah. So from the CT, which was done in the emergency, there was a large hypodensity which was present in the right parieto-occipital region. You can clearly see in the top images that there was also effacement of the posterior horn of the right lateral ventricle, and there was effacement of the sulci as well. In the lower images, you can see that there is some hyperdensity present inside of this large hypodensity. So the initial impression of the CT was given as hemorrhagic infarct, and she was further evaluated. Next slide, please. So MRI brain was done, which showed a large T2 hyperintense lesion in the same region, that is right parieto-occipital region. And SWAN and diffusion weighted sequences were done to exclude IC bleed and to rule out an acute infarct. So these two sequences excluded that. There was no IC bleed and no infarct. Next slide, please. MR venography was also done considering a possibility of CVT, but it was normal. And contrast enhanced T1 weighted images, which are shown in the lower images, they showed that there was some perilesional enhancement seen. And in the lower image, you can also see how clearly there is effacement of the various sulci on the right side as we compare to the left side. So a final impression of cerebritis with perilesional edema was given, but this was not very characteristic of CNS lupus. That also we kept in mind. Next slide, please. On further evaluation, she was found to be having anemia. Her HB was 8.4. Serum creatinine was mildly elevated at 1.31. Albumin was low. Other metabolic parameters were normal. Urine showed active urinary sediments in form of proteinuria, hematuria, and pyuria. Anti-dsDNA was elevated. APLA profile was negative. Serum complements were low. CRP was elevated. X-ray and echo were within normal limit. Next slide, please. So we went ahead and did a CSF examination, which showed leukocytosis with predominant lymphocytes. Protein was elevated at 85. Considering the corresponding blood sugar, the CSF glucose was low. The bacterial culture, the fungal culture, and AFB smear culture all were negative. So having done all these investigations, we still were not sure what we were dealing with. Could it all be lupus because she, after all, has an active disease? Or is it something else? The MRI picture was not very conclusive to suggest any CNS lupus, and CSF analysis, though was abnormal, still could not give us a clear picture. Next slide, please. So while we were still scratching our heads that what is the cause of this abnormality, the blood culture sent from the emergency department came, and it showed Listeria monocytogenes, which was sensitive to ampicillin. She was already on broad spectrum antibiotics because of high grade fever. Ampicillin was added. She became afebrile within next 4 days, and left hemiparesis improved to 4+/5, and she was all ambulant by herself at the time of discharge, with the final diagnosis of SLE with active nephritis with CNS listeriosis. Next slide, please. So highlights of this case is, we all know that not all hemiparesis in lupus are CVA. CNS infections can mimic them, and we must always exclude them. Blood culture may be an important indicator when CSF picture is abnormal, but it is inconclusive to confirm the cause or the bacterial pathogen. And as we all know, immunosuppression can cause infections by unusual opportunistic organisms. So we should always be on look for them. Next slide, please. So unusual clinical picture, deterioration despite the patient being on immunosuppressive therapy, and imaging which is not typical of CVA should always prompt us to look for any kind of unusual infection in the brain. And early diagnosis and prompt treatment will usually lead to a good outcome. Next slide, please. So briefly, I would discuss about this bacteria, which is Listeria monocytogenes, which we don't encounter very commonly. It is a motile aerobic gram-positive intracellular bacillus. So if we look at the image on the right-hand side of the screen, this shows that how over evolution this bacteria has learned to exploit the cytoskeleton to move from one cell to another. So when the bacteria enters the cell, it causes lysis of the vacuole. It replicates inside the cytoplasm, and the protein ACT-A, which is present on this bacteria, It causes polymerization of actin behind the bacteria, and thus it helps in moving the bacteria from one cell to other without coming in contact with the extracellular fluid. So it completely evades any detection or attack by antibodies. So humoral immunity may not be able to tackle this kind of an infection. Cell-mediated immunity is the one which is needed for such kind of an intracellular pathogen. But in most of the patients, or in most of the persons who are immunocompetent, the most common symptom being diarrhea, it is self-resolving and does not require any particular treatment. However, if there is a vulnerable group like neonates, elderly, or immunocompromised people, this can cause to fulminant infections like CNS infection, as in this case, which can present as meningitis, meningoencephalitis, or even cerebritis. A blood culture and CSF culture can be seen positive in 60 and 80% respectively. And ampicillin is the drug of choice, and duration of therapy is typically between 4 to 6 weeks. Next slide, please. So coming to what data we have for CNS listeriosis in lupus, this series published in 2013 talks of 26 patients which they had collated, and the most common presentation of CNS listeriosis was meningitis, and meningoencephalitis was the least common. The most common clinical presentation was fever, and focal neurological signs was least common, which was seen in around 41.6% patients, like in our patient. Uh, Most of the patient, that is 46%, the lupus activity was not reported. We did not have any data to comment whether lupus was active or not, but this is important. 87% of these patients were on immunosuppressive therapy with steroids and other immunosuppressive in another 43%. And the mortality was very high, around 27% in the patients who had CNS listeriosis, and focal neurological deficit was seen in around 7%. Some of these diagnoses were made after the demise of the patient on biopsy or the tissue from the brain. Next slide, please. So this is another data which showed neuroinvasive listeriosis. Now this group has collated data from 1990 to 2014, and these are not lupus patients. This is overall neuroinvasive listeriosis which they saw in 100 patients. So not surprisingly, 54%, that is more than the half of these patients who had neuroinvasive listeriosis, were on immunosuppressive therapy. Some were having some hematological malignancy, post-transplant, or lupus. So immunosuppression is a very important risk factor for developing neuroinvasive listeriosis. They also delineated poor prognostic factors for mortality and neurological sequelae. So they found out that delayed initiation of treatment and presence of seizures, these two were significantly associated with mortality. And for neurological sequelae, delayed initiation of treatment and bacteremia were associated with neurological sequelae. So with this, I conclude my case. Next slide, please. And I would like to thank my faculty, Professor Amita Agarwal and Professor Vikas Agarwal, who were case in charge when we managed this case at SDPJ Lucknow. And also I would like to thank Dr. Hari Krishnan, who was my colleague while we were managing this case, and also Department of Microbiology and Radiodiagnosis. Thank you.
Thanks, Suvrat, for the brilliantly managed case and well presented and very clearly conveyed message. As all of us know, when somebody comes with acute lupus with neuropsychiatric symptoms, fixing the diagnosis to lupus or infections or a metabolic cause is really, really difficult. But I think you have done it very successfully. And Surat, because we are running out of time, so we may limit the questions now. We'll take it as it comes, because people have to think about it and ask the questions. We'll send it to you by mail. Before I hand it over to the organizers, Dr. Mohit, after the very fantastic Sunday we had today with this academic feast. For everybody who needs to download a certificate, you have to download it from the site where you're viewing the program. today itself. So I think by today night you should be able to download it. Should do it before that. And so thank you everyone. Over to the organizers.
Good afternoon, my dear friends and colleagues. I first of all like to thank WRF for giving me the opportunity to express my gratitude on such a special day in the calendar of Rheumatology Forum. WRF's annual meeting has become one of the most popular day in the rheumatology calendar in India. And today we have hosted one of the biggest digital conference. We had more than 1,200 attendees on day one, and even larger number of delegates participated today in a huge success story that it has become. On behalf of WRF, I express my sincere and heartfelt thanks to Professor Atul Devdar, Professor John Matthew, Professor Vikas Agrawal, Professor Chris Edwards, Dr. Dharmanand, Dr. Ramesh Joyce, Dr. Damodaran, Dr. Raj Kiran, Dr. Meha, Dr. Ganga, all the chairpersons and moderators for the meeting, and all the presenters. We had 2 days of true academic feast, mainly focusing in rheumatoid arthritis, psoriatic arthritis, and difficult cases in SLE. Our mission in WRF is to involve young and talented rheumatologists from all across India and to provide them a platform to interact with the best internationally renowned rheumatologists. We in WRF value all of you and from all across India. Please do write to us for your suggestions, and hopefully we will have a bigger and better event next year. I thank with utmost sincerity and humility to all the respected teachers and seniors, Dr. V.R. Joshi sir, Dr. Mahendranath sir, Dr. Chopra sir, and the attendees who blessed us today with their presence. I'd like to thank the organizing committee led by Dr. Ajit Nalwade and Team Pune with his colleagues from Maharashtra, Dr. Vimlesh. I'd like to give a special thanks to Dr. Akshat Pandey, Dr. Mohit Goel for their sincere hard work and dedications. Well done, Dr. Mohit and Dr. Akshat. I would like to thank Dr. Vinod Ravindran, our scientific chair. Without him, this event would have not been possible. His discipline and motivation sets an example for all of us. Thank you very much once again, Vinod. Thank you, our digital partners from IPCA Laboratories, as well as from Sancheti Hospital Rheumatology TV. Finally, I want to thank all of us and all of you whose name I have missed today. Have a great weekend and goodbye. Thank you.